का, तो बहुत बिजी चल रहे हैं, बट आई विल ट्राई माय बेस्ट कि विद इन 2 days आई विल क्लोज सिम्बायोसिस एटलीस्ट.
Okay, ma'am.
Yeah. Hello, Dr. Shobha. Good evening. Now, Purnima, please keep an eye on we should not make mistake that like that day with Shabana I did, no? Anybody who is joining. Good evening, Charmila ma'am.
Hi, good evening, Monica. How are you?
Ma'am, we are going live in 3, 2, 1. We are live now.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals, Head Office, Ahmedabad. On behalf of Intas, I would like to welcome you all for this Perfection Series Season 9 on the topic Mullerian duct anomalies from diagnosis to intervention. I would like to introduce the co-convener of this series, Dr. Monica Jindal Singh. She is Honorary Secretary, MP Chapter ISAR. She is Vice President of Bhopal Ophthalmic Gynec Society, and she is also the Vice President of Bhopal Menopause Society. Now, I would like to hand over the session to Dr. Monica Singh, madam.
Thank you so much, Dr. Vishal, and thank you, Intas, for giving us this academic platform to conduct the ISAR Perfection Series. And for information of our guest of honor, Dr. Charmila ma'am, warm greetings from ISAR Perfection Series to you. And this is the 9th episode which you are gracing with your presence. And we started way back in March of 2023. And we have not even missed a single month without doing this very star-studded focused ISAR series. And Dr. Nandita Palshetkar, our respected president, was very happy with this because she wanted something to come online from ISAR. So I sincerely thank our dignitaries, Dr. Nandita Palshetkar, Madam, President ISAR, Dr. Sujatakar, Madam, Honorary Secretary General ISAR, and Dr. Sunita Tendulwadkar, Convener of Perfection Series, as well as Senior Vice President ISAR, for having given us the opportunity and the permission to carry out ISAR Perfection Series all over India, including and involving the best of the faculties, the best of the minds, very high level standards of academics involved in this, the latest research, and even some foreign faculties. So I welcome you all to ISAR Perfection Series. Dr. Nandita Palshetkar is our President ISAR, and Madam is the vision and the mind behind ISAR Perfection Series, because when I connected with her during Bhopal ISAR, that is the time I realized she has a vision which transcends beyond cities and state. She wants to go global, and that is how we came to start these series. Thank you, Madam. I would also like to thank Dr. Sujatakar, Madam, who is our Honorary Secretary General ISAR, as well as we will see a lot of her dynamic work during ISAR Bhubaneswar, which is scheduled in the first week of February. And Madam has also been a very strong support, right from her personal touch, as well as the Orissa chapter and her overall involvement in ISAR. She has made this webinar series grow by leaps and bounds. Thank you, Madam. Dr. Sunita Tendulwadkar is the real vision and force behind ISAR Perfection Series, because this was the time I needed permission from somebody to let it go, and she was the one who became the convener of this series. We sort of visualized what it is going to be like, and Madam is so actively into stem cells and the latest research, and such a great endoscopic surgeon that she is a person we almost always include as the first speaker whenever we can. So I thank Madam with all my heart, and we congratulate her for getting the coveted post of President-elect Foxy in the coming 2025. Thank you, Madam. Next, I would like to invite our chief guest, Padma Shri, Madam Dr. Kamini A. Rao, who is the founder chairperson of Medline Academics, an e-learning portal. And she is also our past Foxy president, the chief mentor at Milan IVF Center. And at present, Madam is chairperson of National Registry of ART Clinics and Bank in India, called NARI, editor-in-chief of the International Journal of Infertility and Fetal Medicine, and member of National Advisory Committee for drafting of guidelines on ART bill. Madam was awarded the Padma Shri Award in 2014 in recognition of distinguished service in the field of reproductive medicine, an honorary fellowship of the International Academy of Human Reproduction based on contributions to the science of human reproduction and on recognized international prominence in May 21. Madam is also the awardee of Lifetime Achievement Award from ISAR, Lifetime Achievement Award from FOXI. She has been a chairperson of the drafting committee for ART bill. She has been awarded honorary doctorate for Doctorate of Science at the 54th annual convocation of the Bangalore University, but Vidya Vibhushan Award in 2021 by ICOG, Outstanding Woman Obstetrician and Gynecologist Award by FIGO, and Distinguished National Board of Examination Teacher Award by the Association of National Board Accredited Institutions. Madam's books have been published, read by all of us, and still I see at bookstores, Madam's books being asked for, being looked for. She is the author of the Infertility Manual 4th edition and editor of Principles and Practice of Assisted Reproductive Technology. We welcome ma'am, and we are blessed by your presence. Purnima, has Madam joined?
Ma'am, I can't see ma'am. I'm just trying to call ma'am.
Okay, fine. So I will introduce Charmila ma'am now, Dr. Vishal. Yes. It is with great pleasure and honor I welcome our guest of honor, Dr. Charmila Ayavu, who is Vice President-elect FOXI 2024. Congratulations, Madam. Vice President-elect Trichy Obs-Gynae Society, Chairperson of Clinical Research Committee of FOXI in 2016 to 2018, ICOG Governing
Yes,
Council,
ma'am.
National Coordinator UNICEF FOXI PCA, Medha FOXI PG Program, and ISAR Gurukul Program 22 to 23, which is going so well and which is filled with so much of knowledge and innovation in every episode they hold. She is the series convener of ICOG Journal Club and ICOG certificate courses of 22 to 23. And I've also attended a number of these courses and been the proud recipient of the certificates. She is a member of the WHO Southeast Asia Region MDSR from India, President of Menstrual Hygiene Management Consortium of 18 to 20, Secretary of Gestosis India Association, and the academic wing of Assisted Reproduction Trichy, and Managing Committee member of the PCOS Society of India. Madam, it is a proud privilege to be in your presence, and kindly we would like to have a few words of blessings from you.
Thank you, Monica. Thank you so much for this privilege. And it's always an honor to be in a program where Dr. Nandita Madam is the president, because her vision in academics, as you said, is something which is beyond imagination. And she has brought so many of us into academics just by her encouragement and constant support. The PG in the Medha PG program of FOXI is grown leaps and bounds, and especially that's because of her, because she initiated the program, and we have had almost thousands of episodes on that. And I'm extremely thankful to you that you gave me the opportunity to be in a program where Madam had curated the program, and it's also an honor to be in a program where Dr. Sunita Tandulkar Madam is the convener and vice president of the organization. I'd like to thank Madam. Madam had given us so many opportunities for conducting so many programs in Tamil Nadu when she was in IAGE. And I also like to thank Dr. Sujata Kar, the secretary of ISAR. And when you come to the conveners, Dr. Randhir is known for his academics, and every ESHRE when we attended, we have seen some thought-provoking articles which had been brought up by Dr. Randhir, and it's very rare to see Indian people bringing great research work, and we've always attended almost all his paper presentations in the ESHREs which we attended. So Randhir is known, and he put the map of Bhopal in the world, I would say, because I got to know about Bhopal. I came back and searched in Google for both of you, because you did such a great presentation in ESHRE when I attended there. And Monica is such a hardworking person, and she was one of our research investigators when we did the first multicentric trial of FOXI. We brought you quite late into the program, but you did such great work for us. And it was the first trial of FOXI, and it got published in the Indian Journal also. And it got an award from the journal also for being one of the best papers published in that year. And it's entirely because of all the investigators who gave such great data for us and helped in the analysis. I'd like to put my thanks on record. I mean, you've given me this opportunity in a national forum. Thank you, Monica, for all that help which you gave us at that time. And
Thanks.
it will be always a great program to listen to academics when Dr. Sonal Panchal, Dr. Krishna Kumar, and moderators like Dr. Divya and Dr. Bankar are there. And I'm very eager to listen to all the talks and the panel. I would like to wish Monica all the best in all her endeavors, and we hope to see her in a great position in Foxy also. Okay.
Thank you.
Thank you
Thank
so
you so
much.
much. Thank you,
Thank you,
ma'am.
thank you.
Because of Madam, I got the taste of the first multicentric, how it is done in India.
Madam.
She was such a great principal investigator. There was literally everything was done by the book, right from the forms, the consents. That is the first, like the ethics
Right.
committee, the signatures, the e-signatures. I mean, it was fantastic, Charmila ma'am.
Thank you,
And
Monica.
then I did another multicentric with Mir, nutraceuticals, but yours trial was something, it was a world apart. Thank you so much for the opportunity, Charmila ma'am.
Thank you.
I think our guest of honor, Dr. Sneha Buar madam, is right now boarding a flight to Pune. So she might be able to join for a couple of minutes. Dr. Purnima, whenever madam joins, just let me know. We will welcome her with the address. But
Yes, ma'am, I just talked to ma'am also. Ma'am is just boarding a flight. So ma'am said probably ma'am would be able to attend today.
Yes, madam is a mentor, a very dear senior for me, and I would be requesting all of us to support madam in her Foxy elections in the coming year. She is at present AMOG's chairperson of Medical Disorders Committee 22 to 24. She has received the International MS Signature Award for Phenomenal Leadership in 2020 and the Asia GCC Award in 21. Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics in 2008. Dr. Durusha Distinguished Community Service National Individual Award in 22. Anandibai Joshi State Award by the Government of Maharashtra. Lokmat Healthcare Excellence Award 2020. 31 years of experience in the field of OBGYN. She's a wonderful practitioner, 300 plus talks, 10 plus keynotes and orations, and moderated more than 100 panels and written more than 30 chapters and articles in national publications. Madam has also been the Foxy Breast Committee chairperson in 2019 to 21, governing council member of ICOG, AMOG's MD chair, CEPHOG working group member, founder president Vidarbha ISOPAP, WHO FPI certified national adolescent trainer, and a peer reviewer of Jodi. We welcome Sneha madam, and we would, as soon I think she lands in Pune, she will join us for sure. So I hand over the program to Dr. Purnima Tiwari, a very dynamic member of my team, to take it from here.
Thank you so much, ma'am. So our next slide, please. So it's my pleasure to introduce Dr. Monica Singh, ma'am. Ma'am needs no word. Ma'am is professor at Ellen Medical College, Bhopal. She is consultant reproductive medicine endoscopy sonologist at Bhopal Fertility and Endoscopy Center, Bhopal. Ma'am,
Purnima, let's move to this thing. Just introduce Dr. Randhir and we'll.
Okay. Dr. Randhir Singh, sir, is an organizing chairperson 27th Annual ISAR 2023 Bhopal. Sir is ASHA certified embryologist and is director Bhopal Fertility and Endoscopy Center. Sir is professor at Ellen Medical College and JK Hospital Bhopal. Has been immediate past chairperson MP ISAR, president MP Nursing Homes Association Bhopal, organizing secretary ISAR 2016 Indore, and organizing secretary ISAR Embryology 2018 Bhopal. Sir has been awarded with best oral paper IFS 2012.
Dr. Purnima, you can continue. Dr. Purnima, please continue without wasting time, please. Yeah.
Thank you so much, sir. So we move forward to our next session. The topic is Mullerian abnormalities, confusions and conclusions. The speaker is Dr. Sonal Panchal ma'am, and our chairpersons are Dr. Supriya Jaiswal ma'am and Dr. Sangeeta Sinha ma'am. Dr. Supriya Jaiswal ma'am is Vice President of Patna Obs and Gynae Society, Chairperson Adolescent Health Committee Foxy 23 to 25, Joint Secretary SOBSI Bihar and Jharkhand Chapter, Chief Consultant SM Hospital Patna, Executive Member Central ISOPAP, Executive Member ISAR Bihar Chapter, Executive Member IAGE Patna Chapter.
Thank you, Dr. Purnima. Thank you.
Thank you so much, ma'am, for joining us today. Our next chairperson is Dr. Sangeeta Sinha, Madam. Madam is ART consultant and laparoscopic gynecologist, and she is director at Srijan Bhilai Test Tube PV Center, Chhattisgarh ISAR Accredited Center. It's an infertility training and endoscopy training center, and also fellowship courses in infertility and laparoscopy. Ma'am is President Foxy Bhilai 22 to 25, IMA Durg Women's Wing India 2023, and IMA AMS Chhattisgarh Secretary 23 to 25. We welcome you, Madam, today. Thank you for joining us. So I would like to hand over the session to our chairpersons. Dr. Supriya ma'am.
Yeah, thank you very much. At the outset, I really thank the organizers, especially Dr. Purnima and Dr. One sec.
Yeah, may I just CD of
because of
12
the
Pachal?
mobile, no, it's very difficult to see through the mobile actually.
It's okay, Supriya ma'am. You can continue the
No, Dr. Monica and all the team, Dr. Sonal Panchal. I'm happy to chair your session. And I really thank all the organizers who all are involved. And special thanks to Dr. Nandita Palshetkar ma'am, Dr. Randir sir. So I'll just introduce Madam. She is actually she is a very vibrant personality, of a great academician. So she is a consultant at Nagori's Institute for Infertility and IVF, Ahmedabad, India. Then she's done her PhD in ultrasound in gynecology and infertility. She's also the master of ultrasound in OBGYN and Inter-University School of Medical Science, Medical Ultrasound, professor of many. She has got many accolades to her credit. She is also the National Academic Director, Ian Donald School of India, then Director of Center of Excellence, Ian Dolan. So she's totally involved in the Ian Dolan projects. And she's also reviewer for Journal of Human Reproductive Sciences, published 45 papers in national and international journals, delivered more than 800 lectures, contributed in and authored several books, more than 120. It's really great to contribute chapters. Then keen interest in infertility that she's doing, gynec ultrasound and 3D, 4D ultrasound. So Madam, I've also been to Patna. I remember we had a very good session with you. So over to you for your presentation. Thank you.
Thank you very much, Dr. Supriya, for those very kind words. Thank you very much, Monica, for this invitation and giving me an opportunity to share my ideas with you all. So let us start with the session.
We are so honored to have you, Sonal ma'am, because I remember Sonal ma'am, I just called her. I said, Madam, would this date and time suit you? And she said, anything for you, Monica. So, those were such sweet words. There's hardly anyone in India who has not listened to her talks, and the way she enters the talk, she enters heart and soul and body into the talk. She is,
Yeah, Monica, just say one word for Sonal ma'am. I think Sonal ma'am, you are our family member. You're the eldest family member of our.
I thank you very much. That is truly an honor to me.
Yeah. Thank you.
Thank you very much. And thank you once again to Dr. Supriya and Dr. Monica both. Dr. Randir, I'm happy that you are also here. So to start with right away with the topic, Mullerian duct abnormalities, confusions and conclusions. Yes, it is true. When we are talking about the Mullerian ducts, it is so much of confusion. 1, about the diagnosis. 2, about the management. And 3, about the impact of the treatment or without treatment of the same Mullerian abnormalities on the outcome of the pregnancies. And it is for this reason that we really need to understand the Mullerian duct abnormalities a little bit more in detail, and especially also decide what would be the criteria that we would use for the diagnosis and finally for the management planning of these Mullerian abnormalities. We know that the uterus forms in the embryo and in the fetus from the 2 Mullerian ducts. So there are 2 Mullerian ducts that develop, one from each side, and it is these 2 Mullerian ducts which get fused together in the center. And after they fuse together, it is the central part which gradually gets, central part of the myometrium, which gradually gets absorbed and it becomes a single cavity. So that is the basic and a very superficial process that occurs for the development of the uterus. If that is the case, a rest of this development at any stage can lead to abnormalities. Say, for example, if there is improper or inability to form the Mullerian ducts, this would ultimately lead into complete agenesis if both the Mullerian ducts are not formed, or hypoplasia if they're incompletely formed, or there may be a unicornuate uterus when one side is formed and the other side is not formed. So that means few abnormalities of organogenesis, abnormality of the formation of the Mullerian ducts can lead to this abnormalities. Whereas if the fusion of the Mullerian ducts is not complete, which normally occurs between 6 to 11 weeks of fetal or I would say embryonic to fetal development, it is in these cases it would result into either a bicorporeal or a bicornuate uterus, or even if it is a little earlier, it may result into a didelphys uterus. And if the final septal resorption doesn't occur, that is when it results into a septate or an arcuate uterus. That means if we just put it simply and make it easy to understand, this picture would really help us. If there is a defect in the formation, it may result into complete agenesis, unicornuate uterus or unicornuate uterus with a rudimentary horn. If there is a defect at the time of fusion, it may result into didelphys, complete or partial bicornuate uterus. And if there is a resorption defect, then it would result into complete or partial septate or into the arcuate uterus. But it is important that the terminology that we are using depends on the type of classification, and if there is an overlap in the categorization or classification of these Mullerian abnormalities, that is where it can lead to gross confusions into the final management of these patients. Why do we need to decide what is the exact diagnosis? Is because these Mullerian abnormalities are associated with a high risk of infertility, endometriosis, miscarriages, dystocias, premature labor. Estimated 15% of the women who experience recurrent miscarriages are reported to have some sort of Mullerian duct abnormalities. That means, yes, we need to study them a little more into detail. And if we say so, the most commonly used or the classification that was used for many, many years was the AFS classification, seemed to be quite simple. And it actually divided the shapes of the uterus into the following classes, where there was agenesis or aplasia, that means incomplete development of the uterus, ovaries, uterus, tubes, or the vagina, or the cervix, may lead to may be categorized into this class, which is called hypoplasia or agenesis. Whereas if one Mullerian duct has incompletely or not developed or is completely not developed, that's when it would result into a unicornuate uterus with or without the rudimentary horns. The third is the didelphys uterus, where there is a fusion abnormality, and a little later arrest of the fusion abnormality would result into the bicorporeal, and then the septate, and then the arcuate, and then finally the last class was the DES-exposed uterus. Now, that was the time when this drug DES was used very commonly among the young women, and that used to result, that used to result into an abnormal shape of the uterus in the offspring. But luckily, this drug has been banned from the use since more than about 50 years now, and therefore this abnormality ideally should not be seen very commonly. But I think there was some mistake, some misunderstanding when this drug was used. It was believed that it was only this drug which would lead to this typical T-shaped uterus. But now, since even after 50 years of it being banned, still we are finding some females with typical T-shaped uterus. That means there is some other etiology also for the development of the T-shaped uterus. We will look into more details as we progress with the presentation. As I told you, this was the classification which probably became more popular beyond 2003. And it was sort of a solo ruler for till about 2013, wherein Esri-SJ classification came in 2013, and the major concern against the AFS classification was that in the AFS classification, the majority of the differentiation between the classes was dependent on absolute measurements of distance or absolute measurement of the angles, which was probably not feasible, not possible, not relevant for every size of uterus. It is therefore probably that the new classification, the Esri-SJ classification, which came in, it was a lot more individualized in the sense to define every abnormality or to define the D-shaping of the endometrial or the serosal surface, the myometrial wall thickness of every individual uterus was taken as a standard for that uterus. We are going to explain this also more in detail, but this was the basic difference between the two classifications. The second important difference was, if you look at this classification, even in the diagram, you can see that the cervix, the cervical shape, and the vaginal shape are all included in the classification of the uterine shape itself. Whereas if you look at this diagram, it clearly tells you that the classes of the uterus divided here only tells you about the shape of the uterus. It doesn't talk at all about the cervical or the vaginal shape. But this is a little bit of I would say, incomplete understanding, because apart from this diagram, this classification can also be explained by this table. And when you open that table, it tells you, yes, there's a uterine shape separately given, the cervical shape is separately discussed, and the vaginal shape is also separately described. That means that if at all you want to correctly identify the anatomical abnormality of the uterus, you must ideally describe the uterine class, you must describe the cervical class and the vaginal class, and that would give you the correct diagnosis. Say, for example, you have a didelphys uterus, which you call on your, which you name on your AFS classification, which is a complete bicorporeal uterus with a double cervix and a normal vagina. So that's how it goes. So there you write U3B with C2 and VO. Even if you don't remember the code, it is fine. You remember the description should be just okay for the Esri-SJ classification, correctly done. Okay, now if those are the two classifications, what we are here to decide today is which one is better, which one is more correct, which one should be used regularly, and which one is more clinically or I would say management relevant. If we say so, the first thing comes to the correct diagnosis. And if I say about correct diagnosis, I should first suspect the possibility of a Mullerian abnormality on my 2D scan itself. When we say Mullerian abnormality, apart from unicornate, the main concern is about the differential diagnosis of the duplication abnormalities. And very importantly, as you evaluate the uterus in the transverse section, if you see that there is division of the endometrial cavity, as you are seeing here, which indicates, yes, possibly there is a duplication abnormality. But probably, though not very commonly used, a more important information can be achieved from the longitudinal section. Generally, when we evaluate the longitudinal section of the uterus, we go first to the mid-sagittal plane and we evaluate the serosa, the myometrium, the endomere junction. We evaluate the endometrium and, of course, the shape of the endometrium and whether it is relevant with the time of the cycle and so on. But there's one additional point which must always be taken care of, and that is observing the distance from the fundal end of the serosa to the fundal end of the endometrium to the serosa the serosal tip of the fundus. So if you just keep an eye on this distance as you move the probe from one side to the other side, you would see that from the mid-sagittal plane, as I'm moving on to one side, it feels like the endometrium is trying to approach the serosa, coming back to the center, going back onto the other side. The same phenomenon is seen. If you see this phenomenon occurring when you're evaluating the uterus in the longitudinal plane, this is one of the strongest evidence which tells you it is either a broad fundus or it might be a duplication abnormality, as mild as an arcuate or as severe as a bicornuate, complete bicornuate or a diadelphous uterus. So that is what tells you, yes, there are two cornu, because on one side you go and you are approaching, you would see the cornu approaching the serosa. On the other side you go, you again see that. So you know that there are two cornu, but they are probably divided. Why this happens? This happens because when you put in the probe and there is say, for example, an uterus with a duplication abnormality, we know there is a notch on the fundus. And because of that notch on the fundus, when you put the probe in the center, you would see that there is a long distance between the endometrial deep and the serosal contour or the serosal tip. But as you move from one side to the other side, you can see that because of the extending cornu, this distance increases, but because this distance increases, this distance increases. So it feels like that the endometrium is trying to approach the serosa, and same also happens onto the other side. So this is something very important to understand, and this concept must never be forgotten, because it is the same concept that can not only help you to differentiate between the duplication abnormalities, it is, or to identify the duplication abnormalities, it is also essential to confirm the diagnosis of the unicornuate uterus. If I'm thinking about the unicornuate uterus, then in that case, we know that it is this part which is not present. So it is only this part and that part. And if you move the probe onto the opposite side, on this side, you would not see any endometrial extension towards the serosa, which happens exactly like this. If you see, as we run this, we are seeing the mid-sagittal plane of the uterus. As we move on to one side, we are seeing that the cornu is extending towards the serosa here. But as I move back my probe back to the midline and going on to the other side, the entire endometrial tip regresses back towards the cervix, towards the internal os, and that tells me probably it is a unicornuate uterus. So it is very important that you evaluate your 2D scan very carefully, and that is where, of course, 2D scan is not 100% confirmatory to decide the Mullerian abnormality, but it gives you a very vital idea about the possible Mullerian abnormality that is present. Let us now start the true classification according to the different classes. And if we start with total agenesis of the uterus, which is the first class in the AFS classification, agenesis or hypoplasia. If there is agenesis, that means no uterus is formed. If no uterus is formed, that pelvis is like a male pelvis. And we know that if you look at the full bladder, the base of the bladder, in a male, there is no indentation on the base of the bladder because there's no midline structure there. And therefore, absence of the notch on the base of the bladder tells you it is absence of the uterus. There is no uterus at all. But even if you see a slightest bulge on it, on the base, it is this which tells you that the uterus is present. Depending on the size of the bulge, it might be hypoplastic, it may be severely hypoplastic, or it may be fairly formed. But it is this bulge on the base of the uterus which tells you uterus is present or not present. Remember that whenever the uterus is severely hypoplastic, of course, the myometrium is still formed, so the uterus looks isoechoic. And if it is severely hypoplastic, it will not show any midline hyperechogenicity, no endometrial lining. It appears like a pear-shaped isoechoic structure just by the side of the ovary. It is this structure which is isoechoic, does not even have a central hyperechogenicity, which may be used as a landmark for the uterine, for the identification of the uterus. Therefore, this may be very commonly very difficult to identify. And therefore, it is for these cases, the confirmation of the diagnosis has to be done by MRI. So this is one very important abnormality where MRI is conclusive, not the ultrasound. So ultrasound can strongly suspect, along with the clinical history, the possibility of the hyperplasia or agenesis, but it cannot confidently diagnose. But when it comes to the duplication abnormalities, 3D ultrasound is highly accurate for the diagnosis of the uterine malformations, having good level of agreement with MRI in classification of the different anomaly types based on the ESHRE-SJ as well as on the AFS consensus. There are other studies also which have proved the role of 3D, saying transvaginal 3D ultrasound has proved to be extremely accurate in detection and classification of the uterine abnormalities. It seems to have replaced endoscopy as the gold standard technique for the diagnosis of septate, for that matter, duplication abnormalities. If that is the case, I think we would base our discussion more on the ultrasound rather than anything else. We know that laparoscopy endoscopy, laparo and hystero together was once used for the diagnosis, but we know that when we do a laparoscopy, we are seeing the exterior. When we do endoscopy, we are seeing the interior. You need two procedures to be done to confirm. And even then, many a times, it is very difficult to exactly find out how much is the myometrial wall, and if at all, the correction is required, how much correction, how much to cut, whether. I mean, there was always a tension whether you would by chance not lead to perforation of the uterus. So that means that 3D ultrasound is not only useful for the diagnosis, it can also be used as a very strong and a very effective operative guide for the for treatment of the Mullerian abnormalities. Let us right away go to the true differential diagnosis and the ultrasound role of ultrasound in the same. We know that the uterus, which has a convex serosa, convex or a flat serosa, and a convex or a flat endometrial cavity, endometrial fundus, this is a normal uterus, and this is a normal uterus according to both the classifications. And I repeat that 3D is the best mode to show this because it shows the uterus in the coronal section, and it also can show both the margins very clearly. So we know if both the surfaces are convex or flat, it is a normal. But what if it is not flat? If there is a notch on the endometrial cavity, which is the mildest form of the duplication abnormality, if there's a notch, if there's a dip on the endometrial cavity, on the fundal end of the endometrium, that is where the confusion comes that is this truly a normal uterus or it is a duplication abnormality. If I say so, we have already discussed the basis of both the classifications. So let us right away go to the comparison systems. If there is a concavity or a notch on the fundus, if the notch is not deep, if the endometrial fundal notch is not deep, it is not a subseptate uterus. If I say not deep, what do I mean by not deep? If I'm talking about the AFS classification, what am I going to do? I'm going to draw an intercornual line, and then I'm going to measure the distance between this intercornual line to the deepest point on the notch. If this distance is less than 10 millimeters, and if the angle between the two division of the cavities is obtuse, more than 105 degrees, that's when I would say, yes, it looks like an arcuate uterus. But as I told you earlier, the depth of 10 millimeters or less than 10 millimeters for a small uterus may still cause an impact on implantation by compromising at least about 1/3 of the uterine cavity. Whereas for a large uterus, even 15 or 20 millimeters might not cause that big an impact on the implantation or the compromise on the endometrial cavity. Therefore, ESHRE-SJ said you cannot use the same cutoffs for all the uteri. And therefore, what they did was, after drawing an intercornual line, they measured the distance from the intercornual line to the highest point on the serosal fundus, highest point on the serosal fundus. This distance is called a myometrial wall thickness, and for all the ease of discussions, we would call it X. So X is used as a standard to decide whether the deformity, the D-shaping of the endometrial cavity and the serosa is significant or non-significant. And if the distortion, if the D-shaping, if the notch, the depth of it is less than 50% of the myometrial wall thickness, it is considered as normal. That means where distance of less than 10 millimeter and an obtuse angle on the AFS tells us it is an arcuate uterus. Here, if the depth of this notch is less than half of the myometrial wall thickness, forget about the angle. It tells us this is normal, don't bother. Everything cannot be just perfectly geometrical. There is nothing like an arcuate uterus. And to add to this, even the AFS classification, which names this as arcuate uterus, that also tells us that this arcuate uterus has no consequences on the pregnancy whatsoever, and therefore no treatment is required for an arcuate uterus. If the notch is deeper than that, if the notch is deeper than 10 millimeters, that is when you start thinking about the septate uterus. But very importantly, if we are talking about the AFS classification, it doesn't just depend on the depth of that notch between the two endometrial cavities. It also wants to talk about the angle between the two endometrial cavities. And if the angle is more than 105, I'm going to call it an arcuate uterus, where the serosal fundus is still flat or convex. But if the angle is less than 75 degrees, that's when I want to call it a septate uterus. So angle of less than 75 degrees and the distance, the depth of the notch of depth of the dip of more than 10 millimeters tells me it is a septate uterus. But what if the angle is between 75 and 105? Why did I say 105 and 75? And why did I not say 90 plus and minus? Because it's ultimately body. It's a live tissue. And we cannot say 89 is a septate uterus and 91-degree angle is an arcuate uterus. So we have to have some flexibility in that, and therefore 75 and 105. But remember that when the angle is between 75 and 105, that's when you would not consider the angle, you would consider the distance. And with whatever the angle, if the distance is more than 10 millimeters, you would still call it a septate uterus. So this is something very important to understand and remember. That is the differentiation between the arcuate and the septate uteri. But we know that the Esri-SJ is not going to accept this. Yes, it says that if the notch depth is less than half of the myometrial wall thickness, it is a normal uterus. But if that depth is more than 50%, that is when we call it a septate uterus, provided the fundus serosa is either convex or it is flat. But we all know that there are some septa which are so thick and strong that they pull in the serosa, and if they pull in the serosa, though it is a septate uterus, you would still see a slight notch there. Now, what can we still call it a septate uterus? Again, if I say slight notch, that means the depth of that notch, as you can see here in the figure, the depth of that notch is less than 50% of the myometrial wall thickness. Yes, of course, I can still call it a septate uterus. So I repeat the criteria for the Esri-SJ for the septum. The depth of the intercornual line to the deepest point between the two endometrial cavities. This distance more than 50% of the myometrial wall thickness. And if at all there is a serosal notch, the depth of that notch is less than 50% of the myometrial wall thickness, endometrial notch more than 50%, serosal notch less than 50%, this is a septate uterus. Angle, we are not concerned. And this septate uterus is one of the commonest uterine abnormalities. And it is also of a more concern because it is this abnormality which has most consequences on the fertility as well as on the pregnancy outcomes. It has maximum rate of, it has maximum incidence of infertility, implantation failures, early abortions, abnormal lies on the later pregnancy, early deliveries, and so on. If that is the case, we need to understand the septum a little more in detail. What? The first thing is the size of the septum. If the septum extends up to the internal os, only then we would call it a complete septum. Anything short of that is considered an incomplete septum. And this subclasses of the septate uterus is same for both the classification Eshrei-Sj or AFS. That means they both agree that septa can be of variable thickness and we can call it complete or incomplete, though they don't agree on the diagnosis or the diagnostic criteria of the septate uterus. This causes a major confusion because many a times it happens that a deep arcuate would look like more like a septum, and even if you measure, they may prove to be a septum on the Eshrei-Sj classification, whereas it is still an arcuate on the AFS classification, or the other way around too. Therefore, whenever you have a duplication abnormality, especially when you're suspecting a septate uterus, it is essential that you use both the methods to diagnose whether it is a septate or not a septate uterus. And if the diagnosis of both the systems is different, you should, in your report, ideally document it as according to AFS classification, it is so and so, according to the Eshrei-Sj classification, it is so and so, because if I say that, because of the consequences of the septate uterus, I am going to operate it, and another surgeon says, no, it looks like arcuate and I'm not going to operate it. If anything goes wrong, if by chance after that surgery, the patient gets an abortion, or you have not operated and patient gets one more abortion, that is when you can be sued. It was a septate, you didn't operate, or it wasn't a septate, why did you operate? And so on. So it's very important that you would always write both. In all the cases of dilemma, you should write the diagnosis according to both the systems. Apart from this, to confuse this more, there is a third system, which again talks about the classification. This is called the Cume classification, which is the congenital uterine malformation by experts. They thought, let's make it all very simple. And I don't know whether they really did or they made it more complicated, but at least as far as septate is concerned, they're not saying anything new. It is very similar to what is said with the Eshrei-Sj also. If there is a notch on the endometrial surface and the depth of it is more than 1 centimeter, 10 millimeters, as we said, and if there is a notch on the fundal serosa and the depth of that is less than 1 centimeter, this is a septate uterus. So that is about not much different opinion from the Eshrei-Sj. Yes, so we remember just two systems. Still, I just mentioned that Cume so that you don't feel that the other classification, of course, there are other 3-4 classifications, but just not to lead to more confusion. I've only included those which are common ones. Okay, so that is about the duplication abnormalities, that is especially about the septate uterus. Now, when the duplication abnormality is more severe, that is when it is not only including the endometrium, it is also including the serosa. That means now it is not an absorption defect, it is a fusion defect. So when we talk about that fusion defect, the bicoordinate uterus, the major difference between the septate and the bicoordinate is the notch on the fundus, a deep notch on the fundus. And that is what needs to be confirmed whenever you say bicoordinate or a bicorporeal uterus. If I say deep notch, how deep is deep? You draw an intercornual line and measure the distance from this line to the deepest point on the notch. And if that distance is less than 5 millimeters, that is when I'm allowed to diagnose it as a bicornuate uterus. Of course, when that notch is there, the endometrium is also divided. And most of the times, the angle between the two endometrial cavities is quite wide, and therefore more than 105 is taken as a landmark, as a characteristic. So we now know what is the difference between the septate and the bicoordinate. There's notch on the fundus. The distance between the deepest point on the notch and the intercornual line is less than 5 millimeters. The angle between the two cavities is obtuse or more than 105 as compared to flat, convex or a shallow notch on the serosal fundus and angle of less than 75 degrees in a septate uterus. But these are not just two differentiating points. The third important point is that for the bicornuate uterus, more commonly the medial margins are convex, whereas for the septum, they are more commonly straight. And if you can see here, there's a very subtle gray line coming up here, which is the line of myometrial infolding, which is only present in the bicornuate uterus. It is never present in the septate uterus because in the bicornuate, the myometrial contours have not yet united. So now we know what is a bicornuate uterus, notch deep enough, and then there is an obtuse angle between the two endometrial cavities. If that is a bicornuate uterus, we know that there are some bicornuate uteri where the notch on the fundus may extend right up to the internal os. We call it a complete bicornuate. Whereas if the notch may be extending only up to the short of internal os, and that is a partial bicornuate. But that also doesn't tell you the entire diagnosis because it doesn't tell you about the shape of the cervix. And if you're talking about the shape of the cervix, then if you have a normal cervix with that bicornuate uterus, it is a bicornuate unicolous uterus. Whereas if you see that the cervix is a single muscular complex, but has two canals, as you can see here, and there is a thick muscular wall between the two canals, this is a bicollis. So this is not a septated cervix. For the septated cervix, there are two canals, but there is a thin dividing septum between the two, which is chiefly fibrous. If you put on the Doppler, this fibrous septum usually doesn't show flow, but this muscular septum will show flow. So that is the difference between the septated cervix and the bicollis cervix that we see in the bicornuate uterus. But when there's a third entity, which also is a part of the fusion abnormality, and that, as we know, is a didelphys uterus. So when you have almost complete by two separate cornu, and along with that, you have two separate cervices also. So there's an entirely two separate Mullerian ducts. They've just come close. They have not united with each other. And therefore, you would see two separate muscular complexes and two separate canals. If you see it on the transverse section, it is this which will appear truly as a figure of 8 like that. And that is the uterus didelphys. So those are the bicornuate variations according to the AFS. But when we come to the Escher-Asti classification, there again, they have a problem when you talk about absolute measurements. And therefore, that 5 millimeter distance between the intercornual line and the deepest point on the fundus doesn't suit them. So they found different criteria for the diagnosis of the bicornuate, and they called it bicorporeal uterus. If there is a deep notch on the fundus, that is where they cannot differ. So if there's a deep notch on the fundus, it is a bicorporeal. But how deep is deep? if the depth of this notch on the serosal fundus is more than half of the myometrial wall thickness, that is when it is a bicorporeal. How do I measure it? Because there are two separate cornu, so I have to draw a line touching the tips of the endometrial cavity. I have to draw a line which is touching the serosal tips, and I measure the distance between these two lines. That tells me what is the myometrial wall thickness. And then the line which I've drawn touching the serosal tips is an imaginary line, or I would say there is a line which shows the imaginary fundal margin if there had not been a notch. So if there had not been a notch on the serosal fundus, the fundus would have been here. And in that case, what I will do is, if that is my myometrial thickness, I will measure the distance from that imaginary line where the fundus would have been till the point where the fundus is now. So the notch between the two serosal surfaces, I measure this distance. If this distance is more than 50% of the myometrial wall thickness, that is when it is a bicorporeal uterus. And if this notch extends right up to the internal os, I would call it a complete bicorporeal. If that notch is short of the internal os, I would call it a partial bicorporeal. But now there's still a problem, because as in some septa, there would be a notch on the fundus, there would also be a thick muscular septum or a thick muscular wall between the two endometrial cavity in spite of being a serosal notch also. That means there has to be a third entity. This is an entity where most of the times we are all confused, and this is where we have a major confusion. Is it a septum? Is it a bicornate? Should I operate? Should I not operate? Will abortion occur? Will abortion not occur? And that is where the definite criteria are given. If there is a fundal notch, which is deeper than 50% of the myometrial wall thickness, and in spite of that, there is a thick muscular wall between the two endometrial cavities, you measure the distance from the serosal notch to the endometrial notch. And if this distance is more than 1.5 times the myometrial wall thickness, that is when I would say it is presence of the fusion abnormality along with the absorption abnormality. So that is why I would call it bicorporeal septate uterus. So confusion given a name does not truly mean the confusion solved, but that's what has been tried. So that is a bicorporeal septate uterus, and the literature clearly says that the absorption defect can be corrected in this case, but the fusion defect cannot be corrected. One more major confusion, whatever the diagnosis that you put, according to the AFS or according to the ESHRE-SJ, the major concern is the outcome of the patient. And there are a lot of people who have worked on that too. The people who have classified or they have tried to categorize the outcome of these patients based on the length of the septum or the compromise of the uterine cavity. And the older studies say that if the septum divides more than 1/3 of the endometrial cavity, that's when the chances of abortion are more. But if it's less than that, more than 2/3, that's when the chances of abortion are more. Less than 1/3, that's when the chances of abortion are less. But there are other studies which say probably there is no relationship between the depth of the septum and the outcome of the patient. Then in that case, let us try and correlate the outcome of the patient with the septum with the vascularity, because we know that when we are talking about the implantation, that's when vascularity is very, very important. And if I'm talking about this vascularity, it is because it is these blood vessels which are present in the myometrium, which are going to branch to supply the endometrium. And if the overlying endometrium does not get sufficient blood supply, that is when there is going to be a problem with the pregnancy continuation or the pregnancy presence itself. So let's see what is the difference in the vascularity. It was generally thought that the septa are avascular, but that is probably not the fact. It has been proved in the studies that more than 70% of the septa are vascular. Then why? If they're vascular, why should they lead to less endometrial flow? Why should they lead to abortion? Why should they lead to implantation failure? And that is where comes the vascular pattern. We know that bicornuate uterus is a fusion defect. The myometrial fibers are still in their original position. The vessels which run in the myometrium are still in that original position. And therefore, the vascular pattern on the 3D is a typical V or a Y pattern. Whereas in the septa, the muscular fibers have already started getting intermingled with each other. Some may also have been absorbed. And therefore, the blood vessels also, they run into that crisscrossing of the muscle fibers. And therefore, the arrangement of the blood vessels is not uniform. But so that differentiates between the possibility of a bicornuate and possibility of a septate uterus. But why, if there is already vascularity in the septum, why should it lead to the pregnancy complications? Is because the vessels are in between the crisscrossing muscle fibers. With every peristalsis, these blood vessels, they get compressed. Because they get compressed, the flow becomes high resistance. The branches that supply the overlying endometrium also get a high resistance blood flow, and therefore the chances of implantation decrease, or even the chances of early abortion increase. Moreover, if you see that there are more blood vessels in between the two endometrial cavities, which means there are more muscle fibers. If there are more muscle fibers, there is less connective tissue, and if the connective tissue is less, the decellularization is poor. Therefore, also there can be pregnancy complications. And the third important thing, that if I'm seeing more vascularity, which means there are more muscle fibers crisscrossing, there are more muscle fibers crisscrossing, that is whenever the peristalsis occurs, it's not going to be a regular peristalsis. Because of the crisscrossing, it's going to be chaotic contractions there, which will not allow the implantation to occur. That means, yes, vascularity is present in the septum, and the presence of vascularity is not a good sign for my surgical outcome. It's not a good sign also for my the pregnancy outcome. So that means that if the septum is more vascular, I should be probably more concerned and think about the further management. Having completed the duplication abnormalities, let us move to the next important, and that is a T-shaped uterus. If I'm talking about the T-shaped uterus, it is not every narrow cavity is a T-shaped uterus. T-shaped uterus is where there is a narrowing of the uterine cavity or the endometrial cavity because of a thick lateral wall. What is thick? Again, look at the myometrial wall thickness. You have already measured the myometrial wall thickness. You draw a line from the cornu to the internal os. On this line, you would draw a perpendicular from the deepest point on the lateral wall of the endometrial cavity. Of course, this perpendicular will be divided into the medial part and the lateral part by the line which connects the cornu to the internal os. Measure the distance of the lateral half of the line, and if that distance is more than 1.4x, that is when it is a thickened lateral wall, and that is when it is a T-shaped uterus. Remember, all T-shaped uterus have a normal uterocervical ratio. This is not the hypoplastic uterus. In the hypoplastic uterus, there would always be an abnormal uterocervical ratio. The thickness of the lateral wall is never increased. In spite of that, there is a small cavity. So that is what you used to call a hypoplastic uterus. Now we call it an infantilis uterus, and both the T-shaped uterus and the infantilis uterus are both subclasses of a dysmorphic uterus. If I say that as a marker, sorry, if I say that it is the lateral wall thickness, which is an important sign to decide, or the sign to decide whether it is a T-shaped uterus or not. A little more confusion that is corrected by the Kuhme classification is to measure multiple things. One, measure the outer angle more than 130 degree. Measure the inner angle, which is the angle of the endometrial cavity at the level of the cornu, less than 40 degree. And then measure the distance from the deepest point on the endometrial cavity on the lateral wall to the line joining the os to the cornu. And if this distance is more than 7 millimeters, that if you see these three features, that means it's a T-shaped uterus. I told you earlier, it is many a times more confusing to add more features. So I think we should depend on the fact that if there's a lateral wall thickness, that is when usually it is you can call it a T-shaped uterus. But it's not that simple. All narrow cavities are not T-shaped uterus. They may be truly T-shaped uterus. There may be concavity on the fundus with a T-shaped uterus, which you call it a Y-shaped uterus, or there may be just a narrow cavity, no cornual or no significant cornual extensions, and that is what is called an I-shaped uterus. And of course, the management of those also differ. Coming to the unicornuate uterus, we have already described on the 2D ultrasound how the unicornuate uterus can be suspected. On the 2D section, on the mid-sagittal plane, you would not see the uterus in the midline. It is usually deviated onto one side. As you span across, you'll see that there's only one cornu. The only single cornu can also be identified on the transverse section. You do a 3D and you render the plane and it will show you a unicornuate uterus, but there is something very important that I need to tell you. And that is not only the true unicornuate uterus, even the uterus which is deviated and twisted would also appear unicornuate on your rendered image. And therefore, if you truly want to confirm the diagnosis of the unicornuate uterus, once you have taken a rendered image, you should also rotate the rendered image and confirm that there is no cornu hidden behind the single cornu that you are seeing. And this is something very, very important. Therefore, whenever you see a unicornuate uterus, always try and render yourself. Diagnosing the rudimentary horn, as I told you, is not very simple on the longitudinal section, but it may be a little easier on the transverse section. As you come to the transverse section of the uterus of the cornu, which is normally formed, you would span the probe on both the sides. As you span the probe on the one side, you would see the ovary very close to it, and you may see a normal thickness of the soft tissue adnexal band. But as you move on to the other side, that's when the soft tissue adnexal band appears very, very thick. Sometimes in that you would see that fluid-filled cavity, or you would see a hyperechoic line. And as you move laterally a little farther, you would see the ovary. This tells you it is probably a rudimentary horn. And if you put on a Doppler, you will see the typical uterine vessels in with the high resistance, but a low velocity flow, because it is not a well-developed cornu. So that is your suspicion on the unicornuate horn. And this is how it looks on your longitudinal section, where you are seeing a pear-shaped structure, hyperechoic central line close to the ovary here. And that may be a rudimentary horn. I repeat, you need to do an MRI to confirm the rudimentary horn. Yes, of course, if you are seeing a central endometrial cavity, if you are seeing fluid inside, you're more sure that yes, it is definitely a rudimentary horn. In that case, you have to confirm whether this rudimentary horn is communicating or non-communicating. And it is for this reason that saline infusion salpingography may be a useful guide. It is only in this condition, out of all different Mullerian abnormalities, that 3D along with saline infusion is an additional advantage. Otherwise, 3D is just sufficient for the correct diagnosis of the duplication abnormalities. But remember that 3D has to be done only in the proliferative or in the mid-proliferative or in the secretory phase, when the endometrium appears very good. Otherwise, the rendered image is not going to be satisfactory. If you are doing it on day 2, that's when you should only draw you use the Omni view along with the VCI, and that would show you the correct uterine shape. We have already described the agenesis, and yeah, so if you ask me which is the more suitable method, oh yes, I've not put here the images, but it just came to my mind. There's one more Mullerian abnormality which cannot be missed at this stage, and that is acute accessory cavitating uterine horn. This is a very rare sort of abnormality, but these days it is quite commonly diagnosed, where for the unicornuate and the rudimentary horn is just a normal Mullerian duct which is not formed. So it is a normal structure. It has to be there, but it is not completely formed, and therefore it's a rudimentary horn. When we are talking about the accessory cavitating uterine malformation, the uterine endometrial cavity is absolutely normal. And apart from that, there is an extra horn which is functional, has a central endometrial cavity, has blood collection inside every menstrual cycle, severely painful, mostly diagnosed as fibroid with a cystic degeneration. But remember that when there is an acute, usually the endometrial cavity is absolutely normal. Usually the myometrium is also normal. And in spite of that, the patient complains with severe pain. Remember, fibroids usually cannot present with severe pain. One. Second is, this lesion is placed, if you see the endometrial cavity, it is placed anterolateral to the normal endometrial cavity, and therefore it is not seen on your transverse section if you take at the level of the fundus. If you take it a little lower, that's when you may be able to locate it. 3D is very essential in this case. If you look it on the transverse section, I have a few images of that. I hope I could show you that maybe at the end of the presentation. I'll just show you one picture of that. So if you diagnose it correctly, this can be a boon to the patient, because these patients, they are suffering of pain so much, and it's only excision which is the reply. So this acute needs to be differentiated from the from the cystic degeneration of the fibroids, and this is a new diagnosis which is coming up. Now let's move to, if you ask me, to the conclusion. Which system to use? How to write the diagnosis? I've already said you should write both. Why? Because it's too immature still to comment on which classification is better. Because as I told you, there's some uteri which would be diagnosed as septum on the Escherichia and not on AFS. Some diagnosed as septate on AFS and not on Escherichia. It is in these cases that you must mention the both. There are also studies which have commented that it is Escherichia which overdiagnoses the septum. So excluding all the classical cases where the differential diagnosis is clear, in the majority of the cases, combination of the features of both the systems may be used to plan the practical approach for the management. Thank you very much for that very patient hearing. And just give me one more minute, Monica. I would like to show the image of the acum, because that is something really important, if you don't mind.
Madam, please take your time.
Yeah, so it will just take me 1 minute to find that out and show it to you. Uterus, congenital anomalies, acum. Yes, so this is how I would have to share the screen once again. This is how the acum appears on the 3D. So that is not a cystic degeneration of the fibroid. This is a normal uterine cavity, and this is an accessory horn which is cavitating with a functional endometrium. So that is what is important to diagnose. Thank you very much.
Thank you.
And I believe I've done justice to my subject.
Definitely.
Thank you, Sonal. Really, it was a wonderful presentation.
Thank you, Sangeeta.
And explaining such a difficult topic in such a similar way. And I feel you're really an epitome of knowledge. Every time we listen, we feel mind-blowing. And
Thank you,
your tips
ma'am.
regarding really great and wonderful. I congratulate you, ma'am, for such a nice and wonderful presentation. We are really blessed to have you as a speaker. Thank you.
Thank you very much. Thank you very much.
Thank you, Sonal
Thank you,
ma'am. Madam, which classification do you personally follow out of Eshrey?
No, so as I told you, for all the complicated, what I said in the conclusion is absolutely right. Whenever I feel that it is according to one classification, it is septate, according to one, it is other arcuate or biconate, I'll always write in my report according to AFS, it is this, according to Eshrey SJ, it is this. And this is the how much endometrial cavity looks like compromised. If at all it is a major compromise that is appearing, that is when I would measure the endometrial volume of the residual cavity. So we would exclude the volume of the extensions and we would just measure the triangular or the residual part of the endometrial cavity. And if that volume exceeds 2 cc just before the trigger, that's when we can go ahead. We don't do anything else.
Thank you so much. It was so elaborate and it was such like you. It was a totally different sort of lecture. You
Thank
went
you,
fast
ma'am.
and so
Thank you,
into
Monica.
it.
Thank you very much.
Thank you so much, Sonal ma'am.
Thank you.
so much. Over
Thank
to
you, ma'am. Thank you. Thank you, Monica, doctor.
Thank you, Dr. Sangeeta, for joining us.
Thanks, Dr. Monica. Thanks, Nandit. Thank you.
Thank you. Purnima, we can move now.
Yes. Thank you, ma'am. Thank you so much, ma'am, for wonderful talk. Now we will move forward to our session second. The topic is management of congenital uterine anomalies, current perspective. The speaker is Dr. S. Krishnakumar, sir. And I would like to invite the chairpersons. The chairperson are Dr. Shabana Sultan, ma'am, and Dr. Kundan English, sir. Dr. Shabana Sultan, ma'am, is professor in Department of Obs and Gynae at GMC Bhopal. Ma'am has presented many papers in national conferences, published many papers in various journals. Ma'am is member of a team of PPH Bundle along with Sevagram. She's past Joint Secretary Bhopal Obs and Gynae Society, past Treasurer Bhopal Obs and Gynae Society, present Secretary Bhopal Obs and Gynae Society, Executive Member of MPSAR. Ma'am has done various international projects along with Harvard University and having a special interest in gynae oncology and high-risk pregnancy. Ma'am is Master Trainer of Cervical Screening Program. We welcome you, Madam, today. Thank you for joining us. Our next chairperson is Dr. Kundan English, sir. Sir has done fellowship in endoscopy. Sir is chairperson in Fertility Committee FOXY 2023, managing council member ISAR 22 to 24, director Nirmiti Clinic Center for Assisted Reproduction Endoscopy Pune, vice president FOX 23 to 24, founder, treasurer and librarian 23 to 25 Maharashtra chapter of ISAR. Sir has presented research paper at ASRM 2020 and owner of Moses Cradle ART Bank Pune, presented first time research at 6th COGI World Conference at Vienna on use of GCSF subcutaneously for thin endometrium. Yes, I just talked. I think sir is busy. Notice. Sir
No, Kundan has joined. Dr. Kundan has joined.
Okay, Kundan sir has joined. Okay.
Thank you, Kundan, for joining from OT. Thank you. Kundan is doing some wonderful septum and biconvert uterus surgeries.
Sorry. Good evening, everybody.
Good evening, Krishna Kumar, sir.
Good evening. Good evening,
sir.
Good evening, sir.
So, yes, I think has Dr. Krishna Kumar been introduced, or do I have to do that or not? Yes.
Has to be introduced.
Yeah. Okay. So it's a great, in fact, it's a great academic session today, and we have a fantastic lecture speaker on to speak on this important topic. I think there are many we still getting many types of different Mullerian anomalies, and we still sometimes we individualize our management strategy for each case, and that is what we want to hear from an expert like Dr. Krishna Kumar. We know that he's a chief consultant for JK Women's Hospital at Fortis Hospital. He's also a course director, cadaver course, and AHL IIG CMING course. I think past president of IIG. We know the extensive work done by Dr. Krishna Kumar, and in his tenure, we can see the IIG office also has been, the work has been started. Then Eshrey certified reproductive endocrine endoscopic surgeon. His center is recognized for ICOG fellowships for 6 months of ART and endoscopic surgery. And he's also recipient of National IMA Award in 2019-20, Eminent Medical Main for Distinguished Achievement of Highest Order. That was the award name. And I think he's a wonderful human being, always ready to pass on the important scientific message or scientific knowledge to all of our members. And I really, eager to listen to you on management of congenital uterine anomalies, the current perspective. So over to you, Dr. Krishna Kumar.
Thank you, Kundan. Of course, your scrub dress is excellent.
Thank you.
It gives me, I'm sure everybody wants to have a color of that nature. And of course, my sincere thanks to the ISAR President, Nandita, Secretary, Sujata, and of course, the convener of the program, Dr. Sunita Tandulwadkar, and the main convener, Dr. Monica Singh from Bhopal, and all others present. After hearing Dr. Sonal, I'm afraid whether I can match up to the standard which she has displayed in the diagnosis of congenital anomaly uterus. And I was rather thinking that why not every town in India have a Sonal Panchal? That it would make us so.
Sir, every town in India should have Dr. Krishna Kumar. If I saw Sir's surgery, the way he, negotiated the uterine cavity, no anomaly will stand in your way, sir.
I can travel, but the sonologist cannot travel. That's the problem. Anyway, let me share the screen. I'll straight away start, but then I would skip some of the slides with Sonal as very elaborately, explained, mainly the diagnosis, which is so very vital when you're talking about congenital Mullerian anomalies. And she has explained the difference between the two classification, which we all know, but just to point out that most of the time the congenital uterine anomalies presents in the reproductive age group when we are evaluating from reproduction, when the patient has infertility, reproductive problems, or recurrent miscarriages. But there is a very subgroup of patients who do have cyclical pelvic pain when they are associated with cervical vaginal abnormalities, and they present much earlier than the reproductive age group. So these are some young women who get trouble. I'll try to show a couple of those anomalies which we have to really understand and tackle at that stage. But one must remember many of these congenital anomalies are associated with urinary tract anomalies too. So as I already said, they present in childhood when they have an obstructive symptom, especially in the cervical or the vaginal, which causes hematometra or hematocolpus. But most of the time, only when there is an obstetric complication, we do come across, and occasionally we may be seeing in some of the patients who do not have any complaint. Well, pain which is cyclical is usually something related to menstruation, something obstruction. So most of these patients who present early with hematocolpus, we will show you a couple of cases which we have tackled, and the simplest of them is the intact hymen, which we have imperforate hymen, where you have to just simply drain, nothing more. But then it may not be as simple as we presume in an imperforate hymen. Well, the prevalence is known to be, I won't go into the date, it is almost patients with about 15% to 18% with recurrent miscarriage. In general population, it is seen almost up to 7%, and in the infertile population around 8%. Well, again, madam has already explained between the fusion defect and the other defect, and we wouldn't. But the occurrence is most of the time de novo, though occasionally we have seen familial aggregates of such condition, and it is said that karyotypes are abnormal in only about 7.7% of women with congenital uterine anomalies, especially when we have an absent uterus, only the ovaries present or the ovaries absent. Then we have to know that it looks most of a multifactorial or a polygamic type of occurrence, pattern of occurrence. Well, the diagnostic criteria, madam has already told, I wouldn't go into detail. A good simple 2D USG will indicate you that you need to confirm with the 3D, and 3D is comparable to MRI in most of the cases. Occasionally MRI is required, especially when she said about the remnant uteri or the rudimentary horn confirmation, occasionally in unicornuate uterus. Otherwise, you can diagnose with a good 3D USG, and it becomes imperative for most of us who are especially dealing with infertile patients that we learn at least a good sonography to really pick up and come to the confusion between the Eshrei classification and the AFS septum, but most of the time we do have an incidence of, say, a miscarriage or an abortion. That's where when even if we see a septum, we are going to straight away tackle it. And we know that, as I already mentioned, associated anomalies renal. So one must look into all these anomalies. Don't just look at the pelvis. Always look at KUB pelvis when you're dealing with a patient who has got. Again, I wouldn't go into the detail of these investigations. Madam has already detailed this, and classification also, madam has very, very thoroughly told us. And this dysmorphic uterus, again, madam has explained between the infantilis and the true T-shape, whereas the infantilis has a 2/3 of the cervix and 1/3, and the myometrial thickness, which is very important. I'll come into it when we talk about T-shaped uterus. So again, Alonso described these 3 subvariants of this dysmorphic uterus as to classic T, the Y, and the I, where the septum is also present along with the narrow cavity when it calls it Y. Now, again, madam did explain about this Kuhn classification, and I wouldn't go into the depth of it, but if you are dealing with a true T-shape and you want to diagnose and treat, one must follow those 3 minimum angle, which madam said, less than 130 degrees, the 45-degree angle between the 2 endometrium lining, and the depth between the straight line when you join the cornua and the internal os, the depth of greater than 7 millimeter, which she said, if these criteria are there, only then treat them as T-shaped uterus. Again, I wouldn't, of course, the ASRM classification, the recent one, it included all sub-classification in really diagrammatic form, explaining the vaginal abnormality, the transverse, the hemivagina, the obstructed vagina. This is all available. I wouldn't, again, waste time in this. You all can go into the Google, and I'm sure everybody is aware about it. But since this is an ISAR event, I'm sure we are more worried about the reproductive potential when there is a congenital uterine anomaly. We believe that arcuate uterus doesn't per se cause infertility or a first trimester abortion, whereas septate and subseptate, we know that significantly lower clinical pregnancy, higher preterm birth rate, malpresentation, and high rate of miscarriages, whereas the other type of abnormalities, the unicornate, bicornate, or the didelphys, all have increased preterm birth rate and malpresentation rate. And it has been proved beyond doubt by this very beautiful study by Chen et al. That even conception is decreased in patients with true septate uterus. If you look at this chart, all other anomalies, the conception rate is the same, with be it a bicornate, didelphys, unicornate. So we are told not to touch these class of uterus when you get in a primary infantile patient. But if it's a true septate uterus, after, of course, you diagnose it properly, the way Dr. Panchal has said, you are justified in correcting them if the patient is not conceived. Whereas all other miscarriages, the malpresentation may be high, but septate definitely causes implantation problem. And this beautiful study by Pryor, where he studied almost 2,400 patients who have ART, and you can see the beautiful presentation where he has shown that the arcuate uterus have a similar clinical pregnancy rate like a normal uterine cavity, close to 43%, including the live birth rate, very close to 35%. Whereas if you look at the septate and the other, definite decrease in the live birth rate and the pregnancy rate. You can very well see here, with both septate and subseptate, the pregnancy rates have been hardly 25 and 10, whereas with the other type of uterine anomalies, it has been close to normal, which is that is where we are justified in not correcting any of the other abnormalities. Well, this particular article which I went through, Surgical Management of Congenital Uterine Anomalies, including indication by Theodoros et al., gives you a current perspective as to what it should be. It was published in, I think, 2019. One must read this particular article, but it is now absolute gold standard that hysteroscopic correction of any uterine anomaly by the congenital uterine anomalies, correction definitely improves the pregnancy rate, and of course reduces the miscarriage rates. It's a level A evidence. There is no need of further we trying to justify it. Well, we go into the specific non-obstructive tract anomalies, because obstructive tract, I have said, they will present a rudimentary on with a functional endometrium will present much early, and laparoscopic excision is the only thing. So here, women with dysmorphic, the U1 SRASG classification or the septate U2 ESG, and Madam very beautifully demonstrated this bicorporeal septate uterus or U3, where apart from the indentation, you have the indentation into the endometrium greater than 10 millimeters. She said definitely that has to be corrected as per the septum only. So these are some of these you have to collect. So first I will go into the U1. Well, we all know that this is a thick muscular ring which is reducing the cavity size to a great extent. They have a very high rate of first trimester abortion, and the full-term delivery rate reported is hardly 21%. And you are justified in a patient to correct it if there is no other cause of fertility, and if there is a recurrent implantation failure, there is a T-shaped uterus confirmed by the Cube criteria, you are justified in correcting it. How to correct it? I'll just show you. Patients with recurrent pregnancy loss, and it has been shown that increasing the volume, very good studies are there. Now, before I jump upon specific studies, choosing the right tool in hysteroscopic surgery is important. We all believe that you can use anything, though there are no definite evidence whether cutting a septum with scissors or cutting it with electrical energy is better. But if you correlate the other scissors for the Asherman, which has proven that definitely hysteroscopic cold scissor is better in Asherman. Similarly, all these HTRS which has come is again proven to be better as far as polyp in infertile patient or myoma resection, where the damage to the endometrium definitely could be less. So we believe even any hysteroscopic surgery, first diagnose, and as per Dr. Panchal also, if you can do a vascularity, and if the septum is not very vascular, I would go ahead and do it with the scissors. Now, this very beautiful study by Atelios Fardo et al. On a T-shaped uterus published in the JMIG, where he has proven that they had a big group of patients where they went for this correction, and almost 80% of the pregnancies were this. Now, how to do a lateral metroplasty? As I already said, you first diagnose it by the sonography, a good 3D sonography. Your sonologist should be able to give you all these angles, the depth of the muscle, and confirm that it is a classic T-shaped uterus. Now, I would go ahead and start it off with the scissors. Now, cutting the scissors in the lateral wall may be little difficult. You have a learning curve. You need to have a sharp scissors. I'm sure you can appreciate how the scissors is doing a wonderful job. The fixed blade of the scissors have to be pointed. It has to be fixed into the one of the walls, whichever side you're doing, and then you can see at one stroke how much depth you can cut. This is measured that this is definitely more than 7 millimeter depth. So cutting up to 5 to 6 millimeter is no harm. The other way of diagnosing the adequate cutting in the lateral part is standing at the internal os. You should be able to see that side corner very clearly. Now you can see the scissors does a wonderful job. Previously we were using the Collins knife with the resectoscope. When of course then I found it difficult because every time you have to dilate, because that is 26 French was the only available resectoscope. So we all learned the way how to do with scissors, and you can see the cutting of this muscle will be more difficult than a septum because this is a rather very, very thick muscular constriction ring. So definitely you need to have at least additional scissors because one of them may break. But if you have a good sharp pointed scissors, you are yourself seeing here how beautifully we can expand the cavity. Cutting that muscle is not that difficult at all. You are seeing how much depth we have already cut here, and now you can see that the os is still not very easily visualized standing at the internal os. That means that I can go ahead and really cut. So you have seen that there is about 2 to 3 millimeter of this tissue which is retracting. So we have cut about 5 to 6 millimeter into the lateral myometrium, and definitely we are justified in correcting it more till the time you see the cornua. The cornua should be little outside the lateral wall and not inside the lateral wall. And of course, then the other side is taken care similarly. I wouldn't want to run this video because I've already shown you on one side. There are a lot of more videos to be shown, so I'll move on. And of course, if you do the resectoscopic way, I would say you should use the mini resectoscope and not the conventional 9mm resectoscope, because you will tend to dilate and you are disturbing the muscle fibers. Then you will not really appreciate the true C shape. These smaller diameter resectoscope, which are available between 5 and 6mm, needs no dilatation. So definitely the anatomy is not compromised. And here again, you see we are passing through the bipolar current with the tip. And at a time, we hardly cut about 1 millimeter or 2 millimeter. Don't be in a hurry to cut that full 4mm or 5mm thickness in one go. These are very, very delicate knife. They can break. So you have to pass it very, very gently and cut it only with the tip. But the advantage of cutting with the resectoscope is it's a little faster because the current is doing the job, but we don't know whether the endometrium, whether the adhesion chances are more. And today we have learned that hysteroscopic surgery is causing more intrauterine adhesion, maybe because of the not selecting the right tool for our surgery. So today I use less of all these instruments, but this is one way of correcting with the mini resectoscope. Also, if your scissors are not good enough or not working, and you can go ahead and you can see the cavity expanding now. And this is one way, but mini resectoscope is the way if at all you want to do the resection or the incision with the Collins knife and not the conventional resectoscope, because of the great advantage. You get a beautiful virgin view. Well, complications are known, intrauterine adhesions. If you cut the internal os, you will have insufficiency of cervix, and there are various ways of adhesion preventive measures. I wouldn't go into the deep of it. Well, class U2 or the other classification, these are such small septum, subseptate. These are my old videos. You can very well see that we have been using pottery those days when we were not very much accustomed. But this is one way of just demonstrating here. But we use the bipolar needle, and this was the Versascope needle available those days, where you know it just cuts like absolutely butter. And how to cut a septum? Yes, you keep the ostia always under vision. Don't go above the ostia, remain much below the ostial level, and always in between keep seeing the either side of the cavity to make sure that you're not going into one depth, and don't create an umbrella inside the uterine cavity. Just let the dome be little inverted and not absolutely like an umbrella. Well, if I see such a big septum, as I said, if I'm sure that there is no vascularity or reduced less vascularity after Doppler, I would prefer to cut off with the septum. This is a complete uterine septum. Again, very easy to diagnose. One of the easiest cases for a beginner in hysteroscopic surgery. Start at the apex of the septum, which is the thinnest. Again, holding the scissors is very, very important. Let the blades open up horizontally and let the pressure, intrauterine pressure, be a little more, because the septum will get adequately stretched and it becomes easier for us to really cut the fibers much faster and quicker. And you can classically see the HSG picture which this patient had already brought. As I said, we don't now do HSG to diagnose a septum. We believe the sonography and get it confirmed by sonography, but many times patients do come with all these reports. And what you need to do is just cut it. As you said, hardly any fear of bleeding if you have the adequate intrauterine pressure. But at the same time, you must see that your blade is pointing towards the ostia to remain. That means you are in the midline of the uterine cavity. So the end point, again, I've already explained to you where the ostia will be and how much to cut. But cutting with scissors is simple, and learn it with the scissors only, unless you find a very, very vascular septum which may bleed, and you may need to use the Collins knife in between or occasionally. The small bleeders usually don't cause much problem. Now I would go into a complete septum, a complete uterovaginal septum, where the uterus, though in 3D you can see beautifully, and this patient was for laparoscopy also, you can see the absolutely normal fundus. There is no broad fundus. to suggest that there is a septum, but this patient had a complete septum in the vagina, complete septum in the cervix, and complete intrauterine septum. It's complete uterovaginal septum. So cutting the vagina is again debatable septum, but this patient had a dyspareunia, so we thought of cutting it, and you can use the same Collins knife. You can cut it with straightaway scissors, but with the availability of Collins knife today, we go ahead and cut it with the septum. They hardly bleed, and you will, that is the cervix. One side you can very clearly see. And how to cut the intrauterine septum, because cutting the cervical septum is not that simple. So here you can make use of this mini resectoscope. Again, I don't like to dilate. This is one horn of the cavity. You can see one side of the cavity, which is looking like a unicornuate uterus, but this was diagnosed that there is a complete septum. You can see the ostia end on at 12 o'clock. And going into the other horn, you can very well visualize that it is the left horn, which will be seen on the other side. You can see the cavity. We are entering the other side, and once we have confirmed that septum is in the midline, you may pass the resectoscope into one side. Cutting this septum with scissors is difficult, so I use the mini resector these days, and that one works wonderfully. Absolutely no need of dilatation. You can see the mucosal folds not at all damaged because of the dilatation, the cervical mucosal glands, and we make use of this Collins knife and enter the uterine cavity, absolutely walk in without any dilatation which is required, and you perforate at the thinnest point. The thinnest point will be just above the cervical canal. The septum is the thinnest in the apex, so the apex you have to just make few cuts, few perforation. There is no need of keeping any catheter on the other side. As you can see, with that 2-3 movements, you have entered the other side of the cavity, and you can now cut it like a regular septum. So this septum, since we had started off with the Collins knife, again we continued with the Collins knife, and this is how a complete septum, even including a Robert's uterus, can be tackled, where you just use the tip of the needle to give you way, and the end point is again looking at the tubal ostia. Go on cutting till you just are about 4 millimeter below the tubal ostia. So again, I wouldn't want to run much of these videos here. So this is how a septum is cut. And then one must remember, septum heals the slowest. So you must give a waiting period of 3 months before you tell the patient to try for pregnancy. Now, cutting the cervical septum is not a big game. You can cut it. Of course, there are theories where you say the incompetence is going to increase, but I don't believe so, because as such, these patients have a definite incompetent os. So this is again a case where you have the Oivara syndrome. You can see this patient presented much earlier, and you can see the uterus is quite bulky with the collection. You put in a laparoscope to make sure, and we could see one cervical canal. The other cervical canal we couldn't enter, and then obstructed hemivagina, bulge of the hematocolpus is seen clearly. So here nothing simple, just put in your Collins knife. So any patient presenting with pain and hematocolpus, one can use this Collins knife judiciously, and that colpus is cut. You can see the dark blood coming out, which is collected. And of course, this patient had hematometra and even hematosalpinx, but you have to just leave it for her to get recovered. Many a time they do subside and they come back. You can see the vagina very clearly, and you just expand the vaginal septum, and you can see the other side of the cervix also. So this is how Oivara syndrome needs to be corrected. You can see the perforation in the vaginal septum and the reduction in size. As you can see, the two horns, one horn is bigger because of the collection of blood, and there is definitely hematosalpinx, which you can see here. So just drain them and let nature take care. And because these patients are young, you can't go ahead and do a salpingectomy at this stage without consent. Now, of course, again, Robert uterus, if it is completely obstructing the blood flow, this patient presented, as you can see, abnormal left side dilatation, septum where the complete septum is connected or rather adherent to the cervical wall without allowing the blood to flow. So these patients present much early because of the pain. What you need to do is just be sure that where you are, and once you have confirmed that it is the septum on the connected to the left side, you just cut it. Start off with the Collins knife or with the scissors, and you can see the old tarry blood coming out, and you have to just allow it to drain. And definitely this patient has a very, very good prognosis, because once the septum is out, the uterine cavity is absolutely normal, and these patients do appreciably well. So this is one of the obstructive congenital uterine anomaly. The uterine shape has come back to much normal. Well, this many a time, this is one of the recent case which we did, I think referred from somewhere, Indore or Bhopal, I don't remember. A young girl of hardly 10 years presented with a distal vaginal atresia because a complaint was severe pain in the lower abdomen since last 6 months, and sonography showed a unicornate uterus with hematocolpos almost 8 centimeters, and the ovaries were normal. You can very well appreciate the uterus cavity here and the hematocolpos which is there in the vagina, and an MRI showed definitely again hematocolpus, but the vagina absent in the lower 1/3. The perineum to the vaginal, the hematocolpus distance was measured, and we started, it did show patient had an ectopic right pelvic kidney, also cervical dorsal scoliosis. These also again spinal abnormalities are many a time known. So this patient, this girl, young girl, we thought of tackling it mostly from the perineum rather than from the laparoscopy. Many a time this cervical agenesis and the vaginal atretic patient need multiple sitting, and many a time you might have to go by the abdominal or by the laparoscopic approach. I'll just show you the way here this patient was tackled. You can see very clearly here. You can see very clearly we did bulging, we can very clearly see here. That is the ureteric opening, orifice on the left side and the right side. And one can see that what we did was inject diluted saline with adrenaline between the two planes just above the rectal wall, and with a sharp dissection, we went inside to about 2 centimeters, dilated it. Once I know I've got into 2.5 centimeters under ultrasonic guidance, we put a Veress needle to puncture the hematoma and hematocolpos. You can see the Veress inside, and we drained the whole blood. And after that, put in the Terumo guide wire through the varicose needle, and then the Terumo guide wire was passed through the hysteroscopic sheath, and then the telescope was introduced. One could see the Terumo guide wire entering the right place where the vagina was situated, and then we perforated that place and with the scissors and went into the cavity, the vagina, and you can see the uterine cavity. Here one must remember that the cervix is always longer than the vagina, and as you can see that we expanded with grasper that particular orifice which we had created with the 5 millimeter sheet, expanded it to make it a roomy vagina and to stitch the mucosa to the back to the peritoneum. We put in a 18 number Maliko's catheter. You can see guided it through that particular hole, and under vision of the hysteroscope expanded the orifice or cut the vagina to make it of a good space, and there when we had the anterior and posterior vaginal mucosa, and we pulled the same anterior vaginal mucosa which was about 2.5 to 3 centimeters away from the perineum, but we got sufficient pull, and we just sutured it to the perineum area anteriorly and posteriorly, and one can see very clearly that the vaginal lumen is now well created. A speculum could be passed, but created a vaginal mold made of just glove with a Sergi cell, covered it, and then kept it for about 8 days. And it was kept there with proper labial stitch, and after 8 days, we removed the mold and again did a hysteroscopy to see complete patency of the vaginal tract. And one can appreciate we are entering the cervix here with the mucosal fold seen clearly. And now it is, the inflammation is much less, and one can see the unicornate uterus and the ostia. So confirming that the patency is well maintained, she was relieved of a symptom. So this was one lucky case where we could finish it in one sitting, and you can see the distal vaginal mucosa also very, very clearly up to the perineum. So the girl is doing well now, and this is one way of treating, but you may not be lucky. Many a time you have to correct them by laparoscopy with the pediatric surgeon. Many of them do have an anal or a cloacal abnormality. You have to take care of that. And then we did put in a silicone catheter and kept it for 6 weeks because we can't expect her to do vaginal dilatation too often. So this was one of the interesting case which I wanted to present to you. So I'm sure I've covered up many of these, but this is again a very controversial topic where the uterus, U3, bicorporeal uterus or a didelphys uterus, are you supposed to correct? But literature says, please do not correct them. And then very, very rare patients require this particular laparoscopic Strassman metroplasty, though we don't do much. Maybe in my whole 20 years, I've done just about 3 cases where no other thing could be found and the patient had continuously abortion. You have to just cut both the side of the corpus or the uterus from left side. You can inject vasopressin to, just reduce the vascularity, and with whatever energy you believe, make incision on either side and suture these 2 walls. But this is a very, very traumatic surgery, I feel, because definitely you're going to cause more of intrauterine adhesions. Placental adhesions are going to be there when the patient becomes pregnant. So suturing has become easier because of the presence of today BARP sutures, where you suture the posterior wall under 3D sonography, 3D laparoscopy, and you suture the whole anterior and posterior wall. That is where, of course, this is one such surgery which I don't think I would advocate routinely. Very, very rarely it is done, but just to complete one of the ways of correcting a congenital uterine anomaly, we just thought we will complete it. But I'm not going to advise everyone to do every time you see a uterus didelphys. So this is how the suturing is done. And after the posterior wall, you come back onto the fundus and then go on to the anterior wall. And as you have compression of the BARP suture, the uterine walls keep coming close together and they are easily joined, and this is what the end picture looks. So you need to confirm after 3 months or 6 months by hysteroscopy to see there are no adhesions. Well, what to do? Many a time we have unicornate uterus, and we were told when we were a resident that patients after 6 or 7 pregnancies, their uterine volume increases, and then they are capable of taking a child or a pregnancy to almost 32, 34 weeks. But these days patients are very restless. So again, if at all you want to do a lateral metroplasty in unicornate uterus, you must examine the muscle thickness by a good 3D sonography. And only if it is more than 1 centimeter on whichever side, I would try to expand the cavity slightly if the patient is not conceiving or is for IVF and just unable to get implantation, multiple implantation failure. We would occasionally expand the same by doing a lateral metroplasty on the side where the uterine musculature has been proven to be much thicker than the rest. But again, take care that, like what I showed you in T-shaped uterus, don't cut at one go. Pass small current and cut millimeter depth by millimeter. And just the idea is to give whatever little expansion of the cavity you can give. If not at one place, I would make 2 or 3 slits and leaving some endometrium on the adjoining, that at the time when it collapses, it becomes easier for the epithelialization to take place. So this is how we occasionally do, but again, not all unicornate uterus I would advocate lateral metroplasty. As I said, 3 good places. We make linear incision, not very depth. just about 3 or 4 millimeter. If the lateral wall should be of minimum 1 centimeter on the side where you are trying to cut. So otherwise, you are going to cause more harm than better for the patient. I think I'm almost completed the videos from my side. And this you can see the cavity is going to be little bit expanded, but this is the least which we can do in these patients, and don't come up to the internal loss. So thank you for a patient hearing.
Thank you, Dr. Krishna Kumar. I think it was a elaborated and very specific principles of surgery, as well as very specific cases in a selection. I think because all Mullerian anomalies, we just no need to put a scope and do some surgery there.
Right.
And I think that's the very important message for all the members, which Dr. Krishna Kumar has highlighted, that only those cases which needs endoscopic correction, he has clearly taken those in the initial part. He has told us even which cases we are not supposed to do much endoscopic work or any reconstructive surgery. I think amazing presentation, Dr. Krishna Kumar. And I think I was very happy to hear, about the lateral metroplasty, because there was a decade ago, we were never talking about it. We used to always worry that what my members will think. But I think there is a lot of evidence is coming up. Now we have a CMUE diagnosis classification for T-shaped, and we can select our patient properly who is going to benefit with hysteroscopic lateral metroplasty. Just to add from my side as an experience, we are also doing one of the very important prospective study in hysteroscopic lateral metroplasty. We have found some findings which I want to share with you, that especially in infertility patients who's got a poor endometrial blood flow and a thin endometrium, and with a compromised volume of the cavity, we are applied this hysteroscopic metroplasty. And what we are doing is that we are noting the all transvaginal pictures with 2D as well as color Doppler and all the PSV values, and along with 3D volume computation. And after the metroplasty, we are doing that. And then what we realize is that there is a tremendous significant difference into these parameters. And also it has shown us that it is improving the clinical pregnancy rate as well as ongoing pregnancy rate. Probably once we complete, we will get the evidence. But I think somewhere metroplasty probably help us to not even just to increase the inflammatory response in the endometrium, but also we are taking out certain fibrous tissue which is present in endometrial niche area, and we are trying to get those spiral arterioles into the submucosal area where the stem cells are lying, and thus I think they do help for the further angiogenesis as well as a further endometrial growth. So I think it's a wonderful procedure. Of course, it has evolved from electric current to mechanical seizure, and I think Dr. Krishna Kumar will agree that we have improved these outcomes of metroplasty with the seizure more than electric current.
Yes.
What's your opinion, Dr. Krishna Kumar?
Yeah, definitely. I did say that seizures is the first way any hysteroscopic surgery. Today we are using much less, but then whenever I go and operate at many places, they still believe that seizures is not good. Seizures is not very difficult, so they still tend to do with the needle or the resectoscope. But then there are limitations when you do with resectoscope. You have to be very careful. And I would not like to dilate the cervix today for any hysteroscopic surgery. Go without dilatation with the availability of smaller diameter, not only operative instrument, even resectoscope.
So thank you. I think
We're very lucky to have you.
Yeah.
May I speak, Dr.
Yeah, Dr.
Thank you so much, sir. Yeah, thank you so much, sir. You have given a very clear-cut key messages for managing these patients, especially your videos were excellent. I have one question, sir, for these small girls who are coming with vaginal atresia. So you told that you are using vaginal mold, sometimes silicone catheter. So I have this question that how you're going to choose that in which patient we are using silicone catheter?
No, silicone catheter can be kept for a little longer time. See, when a young girl has atresia and you have created a new vagina, the mother is also very reluctant to do vaginal dilatation because the girl doesn't understand the importance of it. And at that stage, it becomes not only difficult, but even socially, it is not acceptable to dilate the vagina. So, of course, any silicone, we just kept it for the patency for at least 6 weeks. Mold,
so we have to change it and we have to keep it
Yeah,
for
6
more,
months
right?
I can keep a silicone catheter. Mold you have to change every 8 days. But then
Okay.
you cannot call the girl every 8 days and keep, because that's a very painful area and it becomes very difficult in young girls. So I prefer.
Yes, sir.
Sir, I
Thank
have
you,
a
sir.
very small question. Thank you for your comments. Our chairpersons, Dr. Kundan Ingle, Chairperson Foxy Infertility Committee, and Dr. Shabana Sultan, who is Secretary of Bhopal Obsgynae Society. Sir, I wanted to just ask you what is about the scissors. The scissors for the hysteroscopic scissors, they range in cost nowadays from 1,800, 2,000 to 4,000, 8,000.
90,000.
Sir, is
Gold.
it? I didn't know
Cost
that.
90,000.
Sir, is it worth it spending so much money on such expensive scissors, or should we go for middle range?
No,
Because
see,
there is always
first
big.
thing foremost is it has to work. That is
Yes.
number one. When you're using any instrument, if you're happy with those 4,000 rupees or 3,000 rupees, even if it works once, I would throw it, next time buy a second one. So that is still worth it in that one surgery. At least if the 2,000 rupees or 4,000 rupees scissors give me a good cutting and I can create it, absolutely fine. Now what I've observed with these costlier scissors are, of course, every instrument is delicate, but the metal used by this costlier instrument, they don't break that easily. Though they may last for say 30, 40 cases, their efficiency for that long lasts much better. If you have a sufficient work, I would still go for the costlier one. But to be very frank, we have been using some of these cheaper scissors, and the company whom with we are dealing, I tell them that if it's say after 3-4 uses, I'm not happy, he takes it back and he gives me other one at half the cost. So maybe he's using those scissors to somebody else, but then I would not say everybody should buy a 90,000 cost scissor. One can be trying with these simpler, smaller scissors of some companies local, and we are quite happy with many of them.
Thank you, sir. Thank you. So, Dr. Manisha, can you start the panel? Our second program coordinator is Dr. Manisha Jain from Bhopal Obsgynae Society. She is holding the post of treasurer, and she will start the panel discussion.
Good evening, everyone. Yeah, thank you, Monica. For the next session, we'll now move to panel discussion, and the topic is modern anomalies, a practical approach. And to moderate the session, we have with us Dr. Divya Singh ma'am and Dr. Jawal Banker.
So 1 minute, Manisha, can I speak something?
Yes,
I will advise all our viewers and all our audience not to move away after the brilliant talks, because now this panel, we have 2 stars. Dr. Divya Singh is one of the best young sonologists I have seen. She is my mentor and teacher also. And Dr. Jawal Banker is another very great endoscopic surgeon who is just on the like a star on the horizon. So these two together will navigate us through the journey right from diagnosis of Mullerian anomalies by sonography and imaging to how to manage by endoscopy in your OT. So please stay with us. Thank you so much.
Yes, Dr. Divya Singh madam is definitely a star for the today's moderation panel. I myself have heard her in ESOC training courses, and she's just a wonderful, wonderful teacher. Welcome you, ma'am. She's currently as consultant radiologist at Prime Imaging and Prenatal Diagnostics at Chandigarh. She's also expert of Obsgynae ultrasound and from USA. She's a member of ESOC CME Task Force and Online Education Working Group, and she's also the member of ESOC Basic Training at Outreach Working Group. I welcome. She has many awards to her credit by the Ministry of Health and Government of India for providing exam service to pregnant women in Chandigarh in 2018. I welcome you, ma'am.
Thank you, ma'am. Thank you, Dr. Manisha, for the kind introduction.
Yes,
and a very good evening, everyone.
Very good evening. The next moderator we have Dr. Jawal Banker, sir. He is the consultant of Banker IVF and Women's Hospital, MS Gold Medal and DNB Obsgynae. Is faculty at Gujarat University for MSc in Clinical Embryology and ART. He is in fellowship in reproductive medicine and training in reproductive genetics from Valencia. He is trained in ultrasound and training in laparoscopy, hysteroscopy at Paul's Hospital, Kochi. Ahmedabad. I welcome you, sir.
Good evening, everyone. Thank you for the warm welcome.
With this, we move on to the interactive panelists for today's session. First is Dr. Kirti Kaura. She is Secretary of Association of Bhilai Obscurity Society. Next, we have Dr. Nishu Gupta Singla. She is the Director and Consultant at Singla Test to Baby Center, Bilaspur District. Welcome, Dr. Nishu Gupta. Next, we have Pratiksha Makhiza. She is a consultant at Bilaspur. Welcome you, ma'am. She has many achievements to her credit. Next panelist, we have Dr. Rekha Rajesh from Vijay Hospital. She's done Masters in Reproductive Medicine from Homerton University, London. She's certified high-risk pregnancy specialist, and she's done Diploma in Reproductive Medicine from Germany. Welcome you, ma'am. Next, we have Dr. Swati Rathore. She's a professor and head of Obstetrics Department Unit at Christian Medical College Hospital, Vellore, CMC Vellore, and she's Secretary of Vellore Obstetrics Society. Welcome you, ma'am. Next, we have with us Dr. Shobha V. Shavi. She's consultant at Sanjeevani Hospital, Bangalkot, and she's Secretary of Bagalkot OBGY Society. Welcome you, ma'am. And next is Dr. Shweta Patil. She is the fertility consultant and director of Jiva Fertility and IVF Center. And she's an honorary secretary of Belgium Obstetrics Society, and she's in fellowship in reproductive medicine from Kraft Hospital. I welcome you, ma'am. That completes the list. Over to the moderators. Thank you.
Good evening, everyone, once again. And in today's panel discussion, that is on Mullerian anomalies, a practical approach, our aim is to provide you a bird's eye view of how to diagnose, and once you've diagnosed a Mullerian anomaly, how to manage it. I am joined by my co-moderator, Dr. Jwal, and before I start, I would like to congratulate ISAR for having curated this excellent academic program month after month, and especially Dr. Monica and her team for the kind invitation. As I can see here, we have Dr. Shobha and Dr. Shweta with us. So I'll start with them. I'm sharing my screen, so please let me know if you can see our presentation. I hope it is clear.
Yes.
May I request Dr. Shweta to take up the first case, please? Case 1 is that of a 31-year-old nulliparous lady who is planning to conceive and comes to us for an ultrasound. Dr. Shweta, I'm sharing her ultrasound image, and please have a look at this clip. This is just a transverse clip of the uterus on grayscale, starting from the fundus, going down to the cervix. If you've had a look at this clip, I will now proceed to my list of questions. Can we do that? Dr. Shweta, do you hear me?
May I?
Yes.
Yeah, it is a septate uterus.
I'd like you to describe the ultrasound findings first, ma'am, for the benefit of our viewers.
Yeah, the 2D ultrasound is showing in the two different endometrial cavities, and the transverse view is also showing two endometrial cavities. We could see the ovary on the right side, and two different cavities are usually. So I would like to put a 3D ultrasound in it, and definitely it will turn out to be a septate uterus.
Right. So based on this appearance, as Dr. Panchal ma'am illustrated very well, we have two differential diagnoses in mind, that is whether it is septate or biconjugate. And as Dr. Shweta has pointed out, 3D transvaginal ultrasound will give us a coronal view of the uterus so that we can understand what type of Mullerian anomaly it is. So I'm providing you with the 3D coronal view, ma'am. Would you like to comment on this image, please?
Yeah, we would like to check the indentation angle, okay, between the two uterine cavities, and we need to check the depth also. So depending on the depth and indentation angle, this we can differentiate between biconjugate and the septate uterus. So, yeah, can you give us the?
Please go ahead. Please go ahead.
Yeah. So if the indentation angle is less than like the depth is less than 10 millimeters, and if the indentation angle is less than 75, then definitely it is a septate uterus. However, if it is more than 75, then definitely it is a biconate uterus.
Right. Ma'am, where should we look for the indentation to differentiate the septate from biconvate uterus?
Yeah, we have to connect a line. We have to draw a line from the two interostitial line, and we have to draw a vertical line from the middle to up to the highest point of the uterine cavity. I don't have a pointer actually, so
I'll provide it to you, ma'am. This is a case of, as you've rightly said, partial septate uterus, which according to the Eschre classification would fall in the U2A category because cervix and vagina are normal in this case. So it would be C0 and V0. Now I'll provide you with the image that you want. So a case of partial septate uterus, this would be which line, ma'am?
Yeah, this is the line, horizontal line between the two interostitial lines, sorry, and the middle line vertical. So you have the depth this is the depth which should be less than 10 millimeters, and the angle between the two septa should be less than 75.
Right. So as per the definition of the American Fertility Society, the first point which helps in differentiating a septate from a biconvate uterus is presence of indentation on the serosal aspect of the fundus. So here in this coronal view of the uterus, we can see that there is no indentation on the serosal aspect in the fundus. So this is most likely a septate uterus. And to confirm that this is indeed a septate uterus and not an arcuate uterus, as Dr. Shweta has already told us, we need to first draw the interostitial line, and then, as she has told us, measure this internal indentation. So the external indentation would differentiate the biconvate from septate, and this internal indentation would confirm that this is the septate and not an arcuate uterus. As Madam has pointed out, this internal indentation length of greater than 10 millimeters and internal indentation angle less than 75 degrees according to the American Fertility Society definition of 1988 would confirm that this is indeed a septate uterus. So, ma'am, you have discussed one definition, or rather one diagnostic criteria. Could you elaborate on any other diagnostic criteria by little more latest classifications like the Eschre SJ, for example? How do we define uterus as septate by that classification, ma'am?
Yeah, that Combs classification is there. So you can see the internal indentation depth is more than 10 millimeter, as we have already discussed. The angle is also more than 110, and they point out that the ratio between internal indentation angle and the width of the wall ratio should be more than 110. That is also the criteria which we can use in this case.
Yes. So over the years, as we can see, various societies have come up with different diagnostic criteria for septate uterus. The reason why we have so many criteria is because it was believed that after the Eschre SJ classification of 2013, there was an overcall of septate uterus, which would result in unnecessary interventions. Because as you can see here, as per Eschre, the ratio of the internal indentation to the wall thickness was just more than 50%. And they felt that many arcuate uteri would also fall in this category. And that is why they came up with revisions by the Kuhn group in 2017 and the latest by the American Society of Reproductive Medicine in 2021. As you can see, this Kuhn group was a group of experts who believed that we needed to increase this internal indentation to wall thickness ratio to greater than 110% to have only the relevant cases which really had a bearing on reproductive outcome to be included. Yeah. The ASRM, however, has still stuck to the internal indentation depth length of more than 10 millimeters. However, they have increased the angle from 75 degrees to less than 90 degrees so as to include more number of really clinically significant septate uteri. However, again, people are critical of ASRM in that they feel that it results in undercalling because there are several septate uteri which have an internal indentation of more than 10 millimeters, but the angle is more than 90 degree. So many people believe that this probably is, this indentation angle is probably much more realistic. However, the most important or the most sensitive criteria still remains the length of internal indentation more than 10 millimeters. And as Madam has already pointed out, this would be the internal interosteal line. The internal indentation depth would be from the, ma'am, if you could just point out the landmarks, the internal indentation depth is from the
midline of the horizontal line drawn between the two interosteal lines up to the highest point on the cavity. The lowest point of the cavity means the upper part of the cavity.
Perfect. Thank you, ma'am. And the wall thickness which we need to measure for the Escher classification is
from the this horizontal line to the outer margin, serosal surface means, I would like to say.
Right, ma'am. So that is how we get the ratio wall thickness divided by the internal indentation depth. If it is more than 50%, then as per Escher it is septate. But if it's more than 110%, then as per Kuhn it is a septate uterus. And this is how we get the internal indentation angle. I would now request Dr. Jewel to take up the management part, please. Dr. Jewel, are you there with us? If sir is not there, I would request Dr. Shobha to please take up the management part. And I think the first question that Dr. Jewel wanted to pose, Dr. Shobha, are you there with us?
Yes, madam, I'm there.
Yes,
Yeah.
please. The first question would be, now if such a patient who is planning to conceive, a nulliparous lady, comes to you with a partial septate uterus, as we've discussed, how would you like to proceed, ma'am?
I definitely would like to operate because the septate uterus is associated with very high chances of first trimester abortions and also other complications. So I will definitely wish to operate on this patient.
Even if she doesn't have any prior significant obstetric history, ma'am?
Yeah, we need to check the vascularity and we need to check whether it is a partial septum or complete septum. If it is complete septum, then you have to operate, or sometimes depending on the vascularity, like the septa which are vascular, they hardly give bad obstetric outcome because the only miscarriages happen in the avascular septum. So if it is avascular, you have to operate, but if they are vascular, you don't have to operate. What I suggest.
Right. And ma'am, when and how would you like to operate such a patient?
Like if it is the diagnosis confirmed on 3D ultrasound, then I would like to take the patient for hysteroscopy. And with hysteroscopy, we usually prefer that if there's a thick septa, I would prefer resectoscope, and if there is a thin septa, then scissor would do for that.
Right. Dr. Banker, do we have you with us? Would you like to take up the discussion part, please?
Dr. Jewel is not joined.
He was there because he was there when.
Sir has joined, ma'am.
Dr. Purnima, can you call him?
Yes, ma'am, I'm calling.
Well, Dr. Jewel has shared this latest international multi-center cohort study. This paper, which was published as early as this year, it states that though septate uterus is the most common uterine anomaly that we see in the women of reproductive age group, it has a prevalence of around 0.2 to 2.3%. But in according to this paper, the septum resection does not actually lead to improved pregnancy outcomes compared to expectant management in women with a septate uterus. So this is an open label multi-center randomized controlled trial, which has concluded that septal resection does not actually lead to improved pregnancy outcomes compared to expectant management in women with a septate uterus.
Yeah, this is a very novel concept which has come up, and Dr. Divya, because so many, sometimes like as obstetricians, when we deliver babies and we do a C-section, that time we see that after delivery of the baby, sometimes we find a septum over there.
Yes.
Actually, this is, asymmetrically placed and it's not very rigid. It's a very pliable and a very thin membrane-like structure which easily moves with the position of the fetus. So very many fertile patients are actually having a septum which has not hampered their obstetric history or their gestational course at all. So that is the reason while intervening with every septum, a thought should be given. And this study came about promoting the concept that every septum need not be resected. And in fact, they compared two groups of patients wherein one they resected the septum, the other they left for conservative just observation, and they found no difference in the pregnancy outcomes.
So that is something.
In case of like this study was done in all recurrent pregnancy lost women, or what was the criteria of women they included the septum?
No, this was all women with a septate uterus.
Okay. So
Women, the inclusion criteria were all women with a septum, and they were then randomized into two groups. One group was operated, the other group was not operated. Definitely, I've read it a long time back, not a long time back, maybe a year back. So I don't know the details, but definitely the like doing the septal surgery in every case where you find a septum has come under the scanner.
Like, I would like to add that if
True,
the
madam.
woman has a recurrent trimester history, so in that cases, do we need to move ahead for septum resection, or we just have to leave and move ahead?
No, if there are first and second trimester losses along with the septum, then definitely you will have to intervene. And because you cannot just leave it with a history. If there is a history, then it is definitely. But here also, like Krishna Kumar sir said, nowadays there is again a concept of using cold scissors and less energy sources, because whatever be the care you use, whether you use bipolar, still there is lateral energy spread and fibrosis because of the current, which may lead to hampered endometrial growth later on in the post-surgical period.
Ma'am, sir ka phone no reply aa raha hai.
Right. I think, ma'am, what you just brought out has been brought out in this recent paper as well. Like in the population which has recurrent pregnancy loss, I think there is definitely a role of resection of the uterine septum, because this study states that in those patients who have a recurrent pregnancy loss, a septate uterus significantly decreases the chances of achieving live birth, and patients who underwent hysteroscopic septum division had a higher tendency to achieve live births than those who elected for expectant management. So maybe in our patient who's nulliparous, maybe she can be managed expectantly as of now, but in a patient who has a history of recurrent pregnancy loss, septal resection is recommended as per this paper here.
Yeah, that's right. That's right. So we can continue with the discussion. We'll focus more on the ultrasound findings now, Dr. Divya, till Dr. Jwal joins, and we'll be giving our inputs in between.
Right, ma'am. So I'll move on to the next case then, with your permission.
Yes, yes, please.
Perfect. Ma'am, do we have Dr. Nishu with us?
4 panelists have joined. Purnima, please, what are the names of the 4 panelists?
Ma'am, Dr. Nishu Gupta Singla, 4th panelist.
Shobha is there, Pratibha is there, Nishu is there.
Shobha, I'm there, madam.
Who's the 4th
Yes.
one? Who's the 4th one?
I'm Dr. Rekha
Rajesh.
Okay, fine, fine. So you can circulate the questions between these.
Right. So Dr. Nishu, if you're there, I would like to present the second case to you, ma'am. She's a 31-year-old lady, para 2. She's had 2 first trimester miscarriages, no live issue. And she undergoes an ultrasound, and this is the 3D ultrasound image, ma'am. Would you like to comment on this image, please?
Pardon, ma'am. Actually, just joined. Can you please repeat the? Sorry for joining the late. Actually, I have the note.
No problem. Our second case is a 31-year-old lady, para 2. She's had 2 first trimester miscarriages and has no live issue. This is the 3D transvaginal ultrasound image that we have. If you could just comment on this image, ma'am.
Actually, I'm not able to see the image, ma'am.
Ma'am, can you see my screen?
Madam, I'll take up this. I'll take up this so that she can.
No, I'm not
Hello?
able to. I'm not able to see the screen, ma'am, and to see the image.
Doctor, then
I'll take up this.
Madam, it is a complete
May I
septum.
know, Dr. Pratibha, probably can you see the screen?
Yeah, it is a, I can see the screen, and I could
I
see it's a 3D image, 3D
Yeah.
rendered image of a uterine cavity, two different uterine cavity we can see. And as per we can see that there are I could see that there is two different uterine cavity, and it is up to the internos, what I can assume. And if we try to measure the, like, on subjective basis, I can say that it is a complete uterine septum.
If we look at the ma'am external, is there any external serosal indentation in the fundus, ma'am?
No.
So that is the first thing which takes us to the diagnosis of septate uterus. And as you have rightly said, ma'am, we can see a septum which is extending right down to the cervix. So you're right, ma'am, this is a case of complete septate uterus. As per the Eschre classification, this would be
U2B1. U2B1, yeah.
U2B C1 because the cervix is also separated,
Yeah.
and 0 because the vagina.
Yeah.
Thank you, ma'am. Now, we'll just share some tips to improve with our viewers so that they can improve their sonological pickup of Mullerian anomalies. As has been discussed earlier, ma'am, would you like to share with our viewers as to which is the best phase of menstrual cycle in which we should assess the uterus in order to pick up Mullerian anomalies by 3D?
Yeah, the best time is a mid-proliferative phase or the secretory phase, in which we can see the two different uterine cavity very beautifully. Because in the early proliferative phase, the endometrium can be thin, and sometimes we missed out the septum in that phase. So the mid-proliferative phase or the secretory phase are the best time to see these anomalies.
Correct, ma'am. Which plane of examination, ma'am? Suppose tomorrow morning you are going and scanning your patient in the clinic and you do not know that the patient has an anomaly. It's just a routine scan. So which plane of examination should you always perform so that you do not miss the suspicion of a Mullerian anomaly?
Usually longitudinal axis do not give us such much information. So coronal or transverse views give the best information. We can see two different uterine cavity in such plane.
Yes, ma'am. The transverse view is the best because we can then see, as you said rightly, the divided uterine cavities. If you have to get on 3D a good coronal image, as you just saw, ma'am, what is the plane of acquisition? In which plane should you take the 3D sweep so that you get a good 3D coronal image?
Yeah, it is the transverse view. I take do the 3D rendering of that image, and once the image I acquired, then we can see the 3D picture, final 3D picture. So rendering should be done in that coronal view.
Not the rendering, ma'am, the acquisition. Like, in which plane should you hold the probe when you press the 3D acquisition button? Should it be in the transverse plane or in the longitudinal? Because when we are taking a 2D image...
No, longitudinal plane.
Yes, ma'am. We take a sagittal section of the uterus, hold our probe there, and then we press the 3D button to get the acquisition so as to get a very good coronal 3D image. Perfect, ma'am. Will MRI add more information in the assessment of this uterus, ma'am?
Yeah, like with good 3D ultrasound, I don't subject my patient for MRI. But in case if you suspect some rudimentary horn, then
no, ma'am. In the image that you saw, will you ask for an MRI, ma'am, in that patient?
No, not in this patient.
Not really, right. We also have with us Dr. Rekha, I believe.
Yes, I'm there.
Ma'am, would you like to discuss with us, like, suppose this is in this patient, Dr. Pratibha feels that she wouldn't like to take up the patient for MRI, but any other kind of situation where you think an MRI would be more useful, ma'am, in Mullerian anomaly?
In this patient, I would also like to do a bladder full ultrasound and also look at the urogenital system. And in case there's any indication, I would look at we would want an MRI. Otherwise, it is not warranted with the present ultrasound, that 3D ultrasound that you have given. I don't think an MRI is warranted in this patient.
But any other setting, ma'am, not in this patient, but in any other setting of Mullerian anomaly that you would like to order an MRI, not in this case?
Not in this case. Yeah, in other cases where, there is a rudimentary horn or a partial development, and then that is to look at even the spinal deformity if in case is there. So only then we will look at an MRI.
Right, ma'am. Thank you. We'll discuss the management part, ma'am. Is Dr. Jwal with us now?
I can discuss the management. I can discuss the management with you.
Rekha ma'am is there, ma'am.
Yeah, yeah.
Ma'am, this patient, because it's a complete septum, we would go for a septal resection, and depending on the thickness on visualization, most of the time we use partial scissors and partial resectoscope. And here, while cutting the septum, we need to be a little bit careful when we are reaching towards the end of the cavity, because sometimes perforation is a risk because it's a whole septum. And if the septum is very thick in the medial part, we may have to do it in a deferred way. You might need a second sitting. And some of the cases, practically, when we are doing the cases, we will not be able to do a complete resection, which we need to evaluate at a later date and probably redo a relook hysteroscopy and complete the procedure. Because it's a complete septum, this is how we would practically take it.
And if it was a partial septum, say, ma'am, in a patient with a recurrent pregnancy loss,
if it's a partial septum with recurrent pregnancy loss, definitely septal resection is an option. And in my experience, I've had good results with the septal resection.
Septal resection, like you mentioned, Dr. Rekha, partial resectoscopy and partial scissor, though that could be an option. But usually if you select, I think you have to pre-select your case.
Yeah.
Suppose you're proceeding with a, thin, moderately thick septum with scissors, I think you complete the procedure with that. And like Dr. Krishna Kumar said, the best way to do resectoscopy nowadays is with the mini resectoscope.
Yes.
So you do not dilate the internal os much. You do not disturb the anatomy of the cervical canal and the internal os. You are very gentle in your entry, and you use your current to just wipe away the septum. It's very ergonomically very superior as compared to scissors septal resection, but ultimately it depends upon your ease of doing, your expertise, your practice. And I'm a big proponent of scissors resectoscopy, not that much of resectoscopy as cold scissors, but it again depends upon your choice. There are people who say that despite using current and despite using resectoscopy, they get a good outcome and they get good endometrium while they do their ART procedures.
Yeah.
When thick
sometimes the wall is
you have to resort to resectoscope, basically, ma'am. Thick septums are difficult to cut with scissors.
Cut with scissors.
Yeah. So resector is best, and we can put the current to 100, depending on monopolar, bipolar, whichever we are using. And nowadays with good instruments, it is very easy to do septum resection.
Yeah. Now there's another controversy with glycine versus normal saline. So glycine is almost going out of practice now. People are now, the last case I did with glycine was a couple of years back, because with glycine, we are always worried about the volume deficit and so many things. So with bipolar instruments for resectoscopy, you can use normal saline, and normal saline is safer to be used as a medium as compared to glycine. But that is a different topic altogether. I don't think that will be a part of today's panel. Thank you, Dr. Divya. We can proceed, I think.
Yes, ma'am. Now I'll move on to the next case. May I request Dr. Nishu now, if she can see the screen? Ma'am, can you confirm if you can see the screen?
Is Dr. Nishu there?
Otherwise, I request
she's left, ma'am.
I request Dr. Rekha to take up case 3, ma'am.
Yes, yes.
She's a 30-year-old lady with primary infertility who's planning to undergo IVF. And I'll share this 2D ultrasound clip. Again, it is just a sweep transverse section from the fundus down to the cervix. So I'll let it play for a while. This is the fundus. And now I'm going down. I'll go down after this. This is fundus.
Yeah.
Now I'm going down.
This looks like a unicorn with uterus to me.
Perfect, ma'am. Why do you say that?
Yeah, see, like what Sonal ma'am told us, no? So the endometrium actually regresses towards the cervix. And you can see the single plane there in the 2D image, and you don't see that broadening in the fundus also.
Correct. So as you can see here, this endometrium that you see here is seen reaching up to the serosa only on one end. And we don't see this endometrium endometrium extending up to the serosa on the other side.
Right.
Obviously, when we would have a look at this uterus transabdominally, say, it would be deviated to one side. And this is definitely causing us to believe that this might be a case of uniconvex uterus. But let's just confirm it. So we'll again do take a 3D sweep in the sagittal plane, and this is the image that we get, ma'am.
Yeah.
So as you rightly said, this is a case of uniconvex uterus. It is labeled as hemiuterus as per the Escherichia classification and falls under U4 C0 V0 category. What are the various types of uniconvex uterus that we can encounter in day-to-day practice, ma'am?
You can have uniconvex uterus with or without a rudimentary horn, and then you can have a communicating horn, and what else? Or there can be no horn at all.
Yes, ma'am. And the communicating horn may or may not have a functional endometrium within it.
Endometrium, yeah.
So this is the latest ASRM classification, which beautifully describes the various permutations and combinations that we can have with uniconvex uterus. Now, in your clinical experience, ma'am, have you encountered any sonographic pitfalls or anything which has mimicked uniconvex uterus, so that you got an ultrasound report saying something, but it turned out to be a uniconvex uterus, or you thought it was a uniconvex uterus, but it turned out to be something else?
See, many times when we do an ultrasound, and sometimes they don't do a full bladder scan, they just do a transvaginal, and if they have not been experienced in doing, you have to see the scan in both the planes, the sagittal and the transverse plane. And then when we do a sweep from the right to left, we'll be able to identify, and you can see the changes that fall into uniconvex uterus. So it does happen that many times people have diagnosed it as a normal uterus, but we've identified a uniconvex uterus.
Right.
Yeah.
So I think two things that we need to keep in mind whenever we are assessing or doing our day-to-day scan is, first, always check the uterus in two planes, as you rightly said, the longitudinal as well as the transverse. And second, always try to look for both the conua even on 2D, so that we don't miss out on a diagnosis of uniconvex uterus. So with this, I'll be sharing an interesting case, a case which actually mimicked, which actually led to misdiagnosis of an endometriotic cyst. So if Dr. Pratibha is there, would you like to take up this case, ma'am?
Dr. Divya, can I ask a question about uniconvex uterus?
Yes, ma'am.
I wanted to ask you, once we have seen the uniconvex uterus on 2D and confirmed it by 3D,
yes, ma'am,
in the coronal view of the 3D, and we find only one tube and ovary, that's almost certain it's a uniconvex, or can we have a uniconvex with the other side tube and ovary also in some variants, that rudimentary horn can have a tube and ovary on the other side?
Yes, ma'am, there can be, because the ovary, it doesn't arise from the Mullerian system. So there can be an ovary on the other side, ma'am.
So is there a possibility the horn is rudimentary on one side, but the tube and the ovary are very well developed? Is it a possibility?
Yes, ma'am, it is a possibility.
Okay, okay.
Yes.
Madam, recently I had one patient of uniconvex uterus. She had undergone laparoscopy for infertility. They had told the rudimentary horn is there, it won't cause any problem. But the thing was, she had a very good tube and ovary developed on that side, and she developed ectopic in that tube. And she was very surprised. She told that they told nothing.
There is a
would
recent
happen.
paper, ma'am, which says that actually tubal ectopics are very common in uniconvex uterus on the side of the rudimentary horn. So,
in fact, if you insert a scope, it just occurred to me, Joel is not there, that if you are inserting your laparoscope and you have diagnosed a rudimentary horn, which is not communicating with the main cavity, okay, and you see a well-developed tube on that side, why don't you, just clip the tube?
Yes, madam. It's better to do a tubectomy on that side.
Yeah, just clip the cornal end of the tube. So you will be preventing some, because you have already done an intervention. Why not you proceed with this? There should be there are not so many cases. Otherwise, this would be a very good measure to prevent that further morbidity of the patient from ectopic.
Right.
Yeah.
So this was actually an interesting case, a 13-year-old girl who had dysmenorrhea, and the ultrasound report was right endometriotic cyst. Despite receiving some treatment for endometriosis, her symptoms were not relieved, and that is why she underwent another scan. As you can see here, this is the uterus. This is definitely a transabdominal image. You can see a full bladder here. And this structure that you see in the right adnexa was reported as an endometriotic cyst. So, Dr. Pratibha, do you agree? Do you feel that this is what a classical endometriotic cyst looks
No,
like, ma'am?
it is basically hematocolpos hematometra. It is hematocolpos actually, and I think it is there may be vaginal agenesis. Because of that, the girl is having dysmenorrhea, severe dysmenorrhea.
Actually, the uterus, a part of the uterus was seen, ma'am. So this is actually the small uterus with the
Hematometra.
Yeah, it can be hematocolpos. No?
Metra, ma'am, because it's like at the level of,
Rudimentary horn.
yes,
Okay.
it's
Rudimentary horn collection.
uterus, ma'am.
Non-communicating rudimentary horn.
Yeah, it can be
Because
a rudimentary horn as well. Yes.
yeah, because the wall thickness is it looks like muscular.
Perfect, ma'am. Perfect. Because endometriotic cysts usually have a thin wall. They don't have such a thick wall. This is actually as thick as a myometrial wall. And you see blood contents, as Dr. Pratibha rightly said. She felt there was blood here. So this is indeed blood. But this is blood in a rudimentary non-communicating horn with functional endometrium. And we could actually see the right ovary separately from this structure. So right endometriosis, right endometriotic cyst was out of question. We did a transabdominal 3D rendering just to show you the shape of the uniconveate uterus. So this is the uniconveate uterus here with the endometrium, and this was the non-communicating rudimentary horn with hematometra because of a functional endometrium within it. So a drastic change in the diagnosis and management of this patient. Another sonographic pitfall or another lesion which you might think is a uniconveate uterus with a rudimentary horn, but it is not. Would Dr. Shobha like to take up this case, ma'am? This is a 2D image of a 23-year-old lady with dysmenorrhea. I'm showing you the longitudinal section of the uterus. This is the uterus, ma'am.
There's a well-developed cavity on one side with the trilaminar endometrium. There's a cystic lesion on one side.
This looks more like an endometriotic cyst.
But madam, can you replay because the ovary is also separately seen there?
Yes, actually, ma'am, this image is quite representative. The lesion is actually a part of the uterus, ma'am.
Yeah, it's rudimentary horn only, but it is a little, yeah, because ovary is nicely seen separately there. So non-communicating rudimentary horn only.
Right. So here, ma'am, I would like to draw your attention to the normal endometrium. So actually here, one can see this is the endometrium. It is reaching up to the serosa here. So this is one cornu.
Yeah.
So this is one cornu here. And if I continue sweeping, because I will first check for both the cornua. So if I continue sweeping, I follow this endometrium and I will see if it reaches the serosa on the other side as well. And if you notice, it is reaching the serosa on the other side as well. So actually on 2D itself, there is a suspicion that this is not a uniconveate uterus because here the serosa is reaching up to the endometrium. So this is one cornu. And on the other side, when we sweep, the other side here. Here also the endometrium is reaching up to the serosa. So that is the other cornu. So this is a uterus with normal cornu. So this is not a uniconveate uterus. So it's unlikely that this is going to be a rudimentary horn. This is what Dr. Panchal also showed us in her presentation. As you can see here, I've taken a 3D coronal to prove that this uterus indeed had a normal uterine cavity. So you had both the cornu. So this cannot be a uniconveate uterus with a rudimentary horn. Rather, it was a case of ACUM, that is accessory cavitated uterine malformation. So basically the message from this presentation is that even if you see something in relation to the uterus which appears like a blood-filled cavity, please make sure that the cavity is uniconveate before labeling it as a rudimentary horn. Because there is this entity which was earlier also known as juvenile cystic adenoma, which is now labeled as accessory cavitated uterine malformation, and it should not be mistaken for the rudimentary horn in a uniconveate uterus, because here the uterus would be normal in appearance.
Okay.
Dr. Rekha, would you like to take up this case? Implications, what are the implications of a uniconvate uterus?
See,
Implications, ma'am, sorry, I don't mean from an direct obstetric point of view. First, are there any, do you feel there would be any implications when we are, say, performing this a Doppler ultrasound, say uterine artery Doppler in the first trimester for this assessment for the risk of preeclampsia? Do you think there would be any implications on our interpretation in case of a uniconvate uterus?
sometimes the uterine artery resistance is a little higher in these patients. And then on one side, we will be seeing the uterine artery. Then there's an increased rate of miscarriage, preterm delivery. So they need to be prepared for that. And depending on their, if they have come without prior diagnosis, so we need to prepare them for the journey throughout the pregnancy.
Also, what the guideline says that when we are dealing with Mullerian anomalies, we should not be relying on the Doppler indices from the various charts that we have, because all those charts have been developed in women who have normal uteri. So probably the pulsatility indices and all that we use would not apply for women with congenital uterine anomalies. As you've rightly said, this is a recent paper which brings about the kind of complications that can take place in women with a uniconvate uterus. And as we discussed, besides the occurrence of tubal and rudimentary horn ectopics, miscarriage, preterm, these women are also at a high risk of malpresentation. Dr. Shweta, there's also an increased risk of pelvic endometriosis in women with uniconvate uterus. In your opinion, which patients with what type of uniconvate uterus would have higher incidence of pelvic endometriosis, ma'am?
Non-communicating.
With a functional endometrium. So rudimentary horn with a functional endometrium would have a higher rate of pelvic endometriosis. Ma'am, shall we take up the management?
Yeah.
Dr. Jewel, are you there with us?
No, Dr. Jewel is not there. So I think Purnima and I, we can join in for the management.
Yes,
Right.
ma'am.
Yeah. So I did not follow this case completely. It's a uniconvate uterus with a
A
non-communicating
woman with
horn
primary infertility, ma'am, who's planning to undergo IVF.
with a uniconvate uterus.
Yes, ma'am. A uniconvate without any rudimentary horn.
And she's planning to undergo IVF. She's tried other treatments like.
No, she hasn't. She's tried IUI and stuff.
Okay,
now
fine. So
that is
fine.
for
So
IVF.
see, basically for uniconvate uterus, there is no surgery advised. You can't enlarge the cavity of a uniconvate uterus. Whatever is the uterus is the uterus. But she's the same patient with the hematometra in the other horn.
No, ma'am. No, ma'am. That was just a pitfall. She
Right.
doesn't have. She just has a simple uniconvate uterus.
So this patient, she will undergo ART cycle IVF like any other patient would. You
So there
would,
would be no
if she
change.
has one ovary, she has one good ovary, you would stimulate the same way, you will retrieve the follicles in the same way, you will transfer the embryos in the same way. And of course, when practically speaking, I have done embryo transfers in uniconvate uterus with a partially full bladder. So in, as you know, when we do embryo transfer, we are not doing the transabdominal scan. There is an assistant doing it. And we can't have a sonologist doing it. So we train one of our staff, nurses or junior doctors to do it, or our colleagues to do it. So when they hold the probe on the abdominal, lower abdomen, usually it is difficult to focus. So what I do is, practical tip, I just keep a sterile sheet over the probe. So even when I'm wearing the gloves, so I can manipulate the probe in such a way that I get a good visualization of the endometrial stripe. And what we do during transfer is we observe the advancement of the echogenic tip of the embryo transfer catheter till it moves from the mid cavity to the place at the fundus where you want to deposit the embryos. So Pratibha, everybody who's doing IVF, Purnima, they must be realizing that it is slightly difficult to focus the uniconvate uterus when you're doing your transfers. Otherwise, the management is perfectly the same.
Yeah. And I would like to add that, madam, we would like to do blastocyst transfer single or two blasts, because usually we feel that the cavity is smaller and we want to have a single pregnancy and to avoid multiple gestation. So I would like to go for blastocyst transfer in this woman.
Single blast transfer can be
Single blast,
tried.
yeah.
And,
Yeah.
these patients do pretty well with a single embryo developing and a singleton pregnancy. And just recently, I think just a couple of months back, my patient delivered with a unicornate uterus after 36 weeks of gestation.
Yes, yes. We have pretty fair number of cases, madam, when they are single pregnancy, they usually cross 34, 35 weeks.
Yes, yes. So and I did the cerclage because I did want to, though there is a school of thought which says that you just stick to progesterone, don't do cerclage. But I still feel whenever there's a Mullerian anomaly, there is probably some deficit at the level of the internal loss and the type of fiber arrangement which is there, muscle fiber arrangement near the cervix and the uterus at the isthmus is different in Mullerian anomalies.
Yes.
So these internal osses, they tend to have premature dilatation, preterm labor, spontaneous abortions. So I feel it is better to put a stitch, but again, it's a very, very controversial issue which doesn't come in the purview of evidence-based medicine. This is something which I do because I've got good outcome. And I'm at a stage in my career when I cannot afford to lose a pregnancy.
Yes. No, we actually
Madam, at any stage, none of us can risk that loss of pregnancy.
Yeah.
Especially with these patients, they would have gone everywhere and come to us.
Yeah.
I still believe single blastocyst transfer and then probably indicated stitch and then give her progesterone support.
Yeah, but Dr. Rekha, there are so many people who are anti-cerclage. I mean, they will scoff at you when you say you do cerclage. They'll feel you're so, out of the normal things and you're out of fashion. But I feel sometimes a stitch in time saves 9,
Madam, we are all at the peripheries, every rupee counts, if this pregnancy is lost in the midway, I mean, the impact is much more higher than, anything. So I think being safe is better than being sorry.
Yes, definitely. So we have got a lot of metaphors here today. So we are having an English class also.
Yes, yes.
Convincing them and counseling them later is such a big task, madam, if they lose a pregnancy. And I think we'll go into more depression than them.
Yes. I'll share another case with you since we have time. I did a ICSI for a patient in 2009. And she had twins in the first attempt. That time we used to routinely transfer 3 embryos. I'm talking about 2007, 8, 9. 3 embryos was the norm, sometimes 4 also. So she had twins. Now this lady, when I advised cerclage, she moved away to some peripheral place near Bhopal and she did not come back. Probably somebody must have told her cerclage is not required. Bed rest karo, sab theek ho jayega. Now this was, middle of winter night and I was doing a mid-trimester abortion. You remember that time there used to be mid-trimester also, where cerviprin gel was inserted and a patient used to expel, a 14 weeks fetus, 16 weeks fetus. I mean, horrible things we used to do. So this woman, she walked in, her husband walked in at 12 midnight on a white pad or cloth. He was holding 2 fetuses of 16 weeks. 1 male, 1 female, and she had expelled it painlessly. So she had come 100 kilometers from Bhopal. She had come to my clinic and then she disappeared again. She came to me in 2022, last year. I did her IVF. She is now 40 years. She didn't conceive. So now I'm doing a second cycle for her with donor oocytes. So she's due, I'll be doing her transfer in January. So that is the tragedy sometimes. Imagine if those children would have been born, her boy and girl would have been 13 years old, 14 years old. So sometimes
I have a no, because madam, many women are judged and they are misguided of that cerclage, and I feel like because of increased IVF success, twinning, I usually recommend all the women, counsel them to go for cerclage, and we give them in writing that cerclage has been advised and their things have been advised, and it is up to them whether they want to go now. So they cannot blame you for that. They have not been counseled for that, and this is a good practice point, I think.
Yeah, definitely. Anything for a single healthy, viable pregnancy, anything you can probably use these small measures in order to enhance the results. Over to you, Dr. Divya.
Ma'am, I was just wondering, would the management be different if she was a patient with a non-communicating horn with a functional endometrium?
With a functional endometrium, and she is having symptoms also.
Yes,
She's
ma'am.
having, so there are very good laparoscopic surgeons. I'm a basic laparoscopic surgeon. I do all my DHLs, I do my endometriosis, I do septums, but I'm not a master like Dr. Krishna Kumar sir and Dr. Jay Mehta and all those. So what I feel, I've seen these cases wherein that hematometra bearing horn has been very neatly excised by laparoscopy, and the defect has been sutured in such a way that the patient is relieved of her symptoms, and the residual myometrial thickness is enough to carry the her pregnancy to term. You have to be very careful about stitching at the cornal area because it's very vascular. You have to be expert in endosuturing, and this requires a big learning curve. So unfortunately, see, I'm over 50. So unfortunately, when when I passed out, did my MC, MS or MD Gynae, that time laparoscopic surgery was not being done in government medical colleges. So whatever laparoscopy we learned was after our MS and DNB. Can you imagine the learning curve? We were into obstetrics, we were into gynae, we were into infertility, ultrasound, and learning laparoscopy. So you cannot match the youngsters. So always remember there are certain limitations. You have to do whatever best you can do. But that's the way it is done, Dr. Divya. You remove that, you excise that portion, and you neatly suture the area, and it can be done by laparoscopic suturing. There is no need to do a laparotomy.
Right.
I think Dr. Jewel sir is back.
Acha, Jewel,
I had a issue in the OT. I had to leave in the middle. So
Jewel, now we will not leave you, Jewel.
I am free, ma'am, 100% free. Closed all doors and sitting inside my cabin.
Dr. Divya has a very nice question for you. There is a unicornate uterus with a rudimentary horn with a functional endometrium, rudimentary non-communicating horn. And you and Manish Bankar sir are going to do IVF for that patient. So how do you deal with that functional cavitated that horn? Yeah, how do you deal with it?
Yes, ma'am. So, the main thing is that any case we do, we treat the issue at hand, that is infertility, and not think about unicornate uterus. And the most important part in the whole process is counseling the patient. She should understand the implications, the risks of miscarriages when we have multiple pregnancies involved in IVF, the need to give the highest chance with a single embryo. That is why we plan to do a blastocyst transfer. And there are many studies which show that a day 3 embryo, either a fresh or a frozen, resulted in a lower clinical pregnancy rate compared to a blastocyst. The implantation rate, miscarriages rate were also higher in unicornate uterus because of many morphologies, including the placental trophoblastic invasion and the cervix, the strength of the os. But the transfer of a single blastocyst embryo, in spite of having significantly higher miscarriage rate compared to a normal uterus, it still resulted in a very high pregnancy rate. So
suppose she has got a symptomatic horn, non-communicating symptomatic horn with a functional endometrium. Plus she wants a pregnancy. Then what do you do?
We have transferred many such cases. If it is not
I'm talking about the surgical management, Dr. Jewel.
We need to remove the horn if the horn is causing a problem. Either we can try for clipping or just discontinuing it from if it is connected with the cavity or not. But if there is a need, then we might do a hemihystectomy to remove one horn and the tube along with it. We leave the ovary inside.
What is the term which you are using? Hemihystectomy. What is it called? Purnima, do you know the term? What is it called?
So I've read
hemiresection, something like that, no?
I've read hemihystectomies as a terminology, but it is not a very good terminology to use. If you tell the patient you'll do a hysterectomy in your case, Yeah, but
No, I have read the term, I have read, Joel, is resection of that non-communicating.
non-communicating
Yeah,
horn.
resection.
Laparoscopic resection of a non-communicating horn, a fairly simple procedure to do. But
Okay.
only if it is causing issues, causing pain or any other symptomatic problems to the patient. Otherwise, in most cases, if there is any non-communicating horn, it does not usually cause that much problem to the patient, because the patient is menstruating since many years. She already has hormones. So if she has problems, she might have had problems earlier. I mean, this is when she comes for IVF treatment after many years, after at the age of 30, 32. She has entered her menarche since 13. So in this period, she is quite comfortable knowing that she has a horn which is inside, which is non-communicating. The endometrium is growing, shedding, but it is not causing any problems to her. But during stimulation or any case, before the transfer, if you find the need, then I mean, many studies have shown that removing is good for the patient in terms of pain.
Yeah. Thank you. Thank you.
So,
So, Joel, Dr. Divya, you have more cases?
Just one case, ma'am. The
one
last.
more case, ma'am.
Yeah, please.
So
Please.
the case 4 is that of a 34-year-old lady who's had recurrent pregnancy losses. She's had 3 first trimester losses and doesn't have any live issue. And I'm showing you a 2D clip. May I request Dr. Shobha ma'am to please take up this case?
Yeah.
It's just a transverse sweep, ma'am, again from the fundus down to the cervix.
Madam, we can see 2 endometrial cavities. One looks normal and one like a regular size cavity. The other looks little smaller.
So based on this, what would you be thinking, ma'am? What would you be thinking and what would you do next, ma'am?
A 3D ultrasound.
Right, ma'am. This is the 3D ultrasound image, ma'am. I hope you can see it, ma'am. Would you like to comment?
Yes, yeah, I'm seeing, madam. You can see 2 cavities here. It looks like a bicornuate uterus.
Why, ma'am?
The angle of indentation and the depth of the tissue there, that looks more than 10 mm. And
which angle? The angle here?
Yes, madam.
To differentiate, yes, ma'am. To differentiate septate from biconnuate uterus, we look at the external indentation here, ma'am.
Yeah, there's external indentation on the.
So this external indentation is there. So this is a case of biconnuate uterus, as you have rightly said, ma'am.
Yeah.
This is the hallmark of biconnuate, and that is why we require this coronal image to look for this external indentation.
Correct.
Also known as serosal indentation. So if it is more than 1 centimeters in the fundus, we are sure that this is a case of biconnuate uterus. As we already know, as per the ESHRE, biconnuate uterus is U3, C0, V0 if cervix and vagina are normal. So why is there a difference in the shapes, ma'am, of biconnuate and septate uterus? Why is there this difference in the external indentation? Why does biconnuate have and septate doesn't have?
One is a fusion defect and one is a
resorption defect.
Correct. Correct. So as again, Dr. Panchal had pointed out, we have 2 Mullerian ducts which fuse at around 9 weeks of gestation. So we have biconnuate uterus when there is problems in the fusion, the extent of fusion. So that is why we have this external indentation in case of biconnuate uterus. Whereas in septate uterus, the fusion has already occurred properly. And as Dr. Shobha said, the problem is in the resorption of the septum. So we don't see any external indentation, but we see this internal indentation in case of septate uterus. Rekha ma'am, which other system should be examined in case of a Mullerian anomaly? I think you brought it out earlier also.
Yeah, the urogenital system has to be examined.
Why does, ma'am, the urogenital system tend to have problems in case of Mullerian anomalies?
See, during the developmental stage, what happens is the urinary system actually develops in the pelvis and rises into the abdomen, and the reproductive organs have to descend down. So during this transition phase, that it's a coordinated thing where you can have deficiencies along the urogenital system. Yeah.
Yeah. Perfect. Thank you, ma'am. Dr. Joel, would you like to take up the
Yes,
management?
sure, ma'am. So in such a case, I mean, there are three main questions which the patients ask. What are the implications? I have a bicornuate uterus. So what are the reproductive outcomes in a case of bicornuate uterus? What do you do? Will you operate? If yes, how and why will you operate? And what do you counsel the patient? So, I mean, we'll have one point from all our panelists. We'll start with Shobha, ma'am.
Actually, bicornuate uterus has a better fertility outcome compared to other Mullerian abnormalities.
So, ma'am, I mean, what if the patient had a bicornuate uterus with a married life of 1 year and a bicornuate uterus with a married life of 7 years? Will your treatment differ in such a case?
Definitely, sir. But like maybe in the management part, like if you plan to do IUI and all, then it will be little like you have to do it under ultrasound guidance. Otherwise,
Otherwise, it is fine. So, Rekha, ma'am, will you
Yeah,
operate?
these patients have an increased rate of abortions or preterm delivery. So, if most of the patients seem to conceive naturally, when in one horn they have a pregnancy, sometimes in both horns they have a pregnancy. So, surgery I don't think is indicated in these patients. And while doing an IUI or an embryo transfer, we usually evaluate both the cavities of the uterus, and whichever cavity we feel is more susceptible for a pregnancy, we would transfer the embryo into that cavity. We would usually see one small, one big. So the bigger cavity, we would choose to transfer the embryos.
So, can we go to the next slide? Divya, can we have one, right? So, bicornuate uteri, this is a very good study, a population-based study of more than 3 million deliveries of more than 6,000 bicornuate uteri. It showed that bicornuate uteri can increase the risk of a pregnancy by many folds, like a premature delivery, cesarean deliveries, which they call as a complication, but a PPROM, abruption, the need for hysterectomy, small for gestational age, as well as IUFTs. So this is a very important point in counseling the patient. I mean, it is fine that we'll give you a pregnancy, but the risks are high compared to the normal population. And next slide, please.
and most of the times, these patients, when they become pregnant, they come with complaints of spotting and bleeding.
It is a very difficult task to manage. They have deliveries earlier also at 20-24 weeks, so we need to take a cerclage also. So all these things need to be discussed with the patient. And very large study, a single center study, but I mean one of a very few studies which we have. These are very objective findings, so you don't get many meta-analysis of these studies. But it showed that both abdominal and hysteroscopic metroplasties for a complete septate or a bicornuate uterus can increase the take-home baby rate by preventing pregnancy loss without affecting the chance of pregnancy. But what is more important is, will you operate and why? If the married life is less, or the patient is just having primary infertility, you might not operate. But if the patient is having recurrent miscarriages or preterm deliveries or any sort of issues like that, then there is a need to operate on that patient. And a hysteroscopic or a laparoscopic, mainly hysteroscopic, but even an abdominal approach is as safe as a hysteroscopic approach. Next slide, please.
Can we take up the next case, ma'am, or should we wind up, ma'am?
Yes, yes.
Dr. Pratibha, may I ask you to take up this case?
Yeah.
Case 5 is that of a 28-year-old lady with primary infertility. Could you please identify the uterine anomaly and how did you identify it?
Yeah, like on 3D rendering, the fundus looks broader, and I could see the indentation is less than 10 mm, and the lateral walls are thicker.
So what do you call this uterus, ma'am?
T-shaped, more like a T-shaped one, or arcuate, like T-shaped, more like a T-shaped uterus, yes.
Because of the thick lateral walls, we call it a T-shaped uterus, and the cavity is also kind of T-shaped. As per Eshrey, it is U1A, and as you rightly said, this is T-shaped because it has a narrow cavity due to thick lateral walls. What is important, as was discussed, how do we differentiate it from an infantile uterus, ma'am?
The ratio will be reversed, like in infantile uterus, we have a 1/3 and 2/3. The ratio of uterine cervical cavity, cervical length is basically reversed in this case.
Yes, in T-shaped, it continues to remain the uterine corpus to cervix ratio remains 2:1, whereas it becomes 1:2 in infantile uterus. Dr. Sonal also discussed certain objective criteria, ma'am. Would you like to elaborate on the objective criteria to describe a T-shaped uterus? By the group?
Sorry, I could not attend madam's lecture.
Oh.
Yeah, the
No
angles,
worries, ma'am. We have this image here. If any of the panelists would like to comment on this image, the objective criteria for T-shaped
The
uterus.
measurement might be very difficult, but this is a very common shape which we see in our fertility practice. Sometimes we don't pay too much attention, that we just see, chalo, thickness is fine, this is fine. But when we do a 3D scan, achanak se after 6 months, after 3 months, when we do follicular studies, we see, oh, the shape is a T-shaped uterus. Here, the cavity will be normal. But I mean, these criteria will help us determine our next steps in the management of such a patient.
Yeah, angle.
Three criteria have been proposed. First is measuring this angle, the angle where the indentation depth is maximum. If it is less than equal to 130 degree, that is one criteria. The other is to draw a line from one cornual end to the level of the internal os. So this is the internal os. And if the maximum depth of the indentation is 7 millimeters or more, that is the second criteria. And the third criteria is the T angle, or the angle which is formed at the conua. So you draw 3 points, one at the conua, the other at the other conua, and the third point at the apex of the indentation, and you join these 3 points. And if this angle is less than equal to 40 degrees, that is also significant. Now, what the researchers have proposed is that if all the 3 criteria are satisfied, then it is called as a T-shaped uterus. If you see only 2 criteria, it is borderline T-shaped, and it's normal if it just fulfills one criteria. This is the Kuhn objective criteria for T-shaped uterus. Dr. Bankar, over to you.
So, same questions. Will you operate married life 2 years and married life 6 years? Will you operate if the patient has 1 abortion versus the patient has 3 abortions? And how do you operate? We have studies showing that operating such a uterus is helpful if the patient is symptomatic. Many patients go unnoticed, deliver many patients. But if the patient has come to you either for infertility or with recurrent abortions, what do you do?
If the patient
yes,
lateral metroplasty.
So I mean, one point from all panelists, ma'am. First point, Dr. Nisha.
Lateral metroplasty, hysteroscopy.
Any method, any particular technique which you would like to do? And Pratibha?
Yeah, we will subject her to first the diagnostic hysteroscopy. And if I found that similar findings, like if it is already confirmed 3D, so I would like to use scissors in this case. Somehow we know we face difficulty while using scissors in the lateral metroplasty. So in such moments, sometimes I use resectoscope also.
Okay. And Rekha ma'am?
Ma'am, you are muted, ma'am. You're muted.
Dr. Rekha, you're muted.
Yeah. Most of the patients, only in case of indication with repeated abortions and prolonged infertility, we do a surgery. And lateral metroplasty with scissors or resectoscope is what I do.
So, can we go to the next slide?
Can I add something here, Dr. Jwal?
Sure, ma'am. Sure, ma'am.
He just had a great lecture by Dr. Krishna Kumar, and he said that thickness is 7 mm.
7
mm. Indentation to the serosal end, the thickness of the uterine wall at the level of the indentation. So you can very safely, the fixed end of the hysteroscopic scissors is kept fixed, and you can advance it very confidently because the depth of cutting which you can go to is up to 5 mm.
Yes.
And similarly, you can use a mini resectoscope. You have to be just careful when you navigate that instrument, whether it's a scissor or it's a resectoscope.
Right. So
and lateral metroplasty, though it was not very popular about a decade back, it is now coming back into vogue. people are definitely finding that it increases the volume of your cavity.
So, I mean, many things which add to this is firstly, increased patient coming to your clinic. Initially, patients wouldn't come to your clinic that often. Second is better pickups due to better ultrasound techniques and routine use of 3D scans. So we are able to identify such things which we wouldn't identify earlier. And the liberal use of office hysteroscopies also. So these things can be done in an office hysteroscopy setup also, in case the clinic does not have a full OT setup. So many things which has led to increased utilization of lateral wall metroplasties, and the incidence is quite high. I mean, from 0.2 to 10% is quite a high incidence of a T-shaped uterus in infertility practice. And studies have shown that the pregnancy rates increased from 49 to up to 88% with increased live birth rate, which shows that we should do hysteroscopies for these patients more often. All studies which I found, even can we go to the next slide? All studies which I found, I mean, these are large multi-center studies, but the overall patient volume is quite low, around 150 women. I think in the Indian scenario, we have a much higher patient load, and there is a need for good quality data. So we should try and publish as much data as possible to add on to this so that we have proper outcomes with us. And even with a 5 French bipolar electrode or scissors, cutting the fibromuscular constriction rings in the ischemic area is the treatment of choice. But the choice of instrument will always depend on the operator. So there is no difference if we use either a resectoscope or a scissor. There they use a bipolar bipolar electrode. But I mean, I think in most scenarios, we fear that there will be adhesions if we use energy inside the uterus, and we tend to use cold scissors for cutting. But if you are comfortable with a monopolar hook also, it gives an equivalent result.
Doctor, Ujjwal, I would like to add, like I have seen many people considering that with a resectoscope there will be adhesions, but I am using since last 10 years resectoscope in septum, in unicornular uterus, in lateral metroplasty. I have not encountered single case of adhesion in my cases.
Yes,
I don't know studies, but I haven't encountered single case of adhesion due to my resectoscope.
So you should use the instrument you are most comfortable with. That will give the least complications in terms of either adhesions, infections, or perforations if there is any case. So any scissor, any resectoscope, any bipolar instrument. I mean, we also use resectoscopes, quite common, but we still fear. Sometimes we use nahi, chalo, aaj bahut lag raha hai, let's use scissors. In that mental fear that there can be adhesions, but no studies have shown increased rates of adhesions with any instrument used. Right on. So
with this, we come to the end of the presentation, and we thank all our panelists for sparing their time and for this invigorating discussion. Thank you.
Thank you so much.
Thank you so much for a very lovely interaction.
Thank you so much, Divya ma'am, Joel sir, and all the panelists. It was a wonderful panel discussion. We had literally very interesting cases. And now I would like to invite Dr. Monica ma'am. Ma'am, few words.
Yeah. Thank you so much, everyone, all faculties, my moderators, Dr. Divya Singh, Dr. Joel Banker. You have really made the panel very interesting. And I think it was a unique concept wherein a sonologist and an endoscopic and ART person got together, and we got these great panelists. Though I had invited 7, 8 panelists, I think only 4 joined. Maybe they were scared of the questions or what. But anyways, we had a great discussion. I also pitched in. So I'm very thankful to Team INTAS for giving us this academic platform. You know, ISAR Perfection is a focused webinar wherein we deal with one focused topic and we try to get to the root of it. We had 2 very excellent speakers, senior speakers, stalwarts, Dr. Sonal Panchal and Dr. Krishna Kumar. We had great chairpersons with interest in the field. And I take this opportunity to ask for your vote and support for my election in the ISAR Managing Committee as a member clinician. The voting lines would be open from 11 January to 19th of January. And I seek your vote and support. And thank you so much for joining the program, as you always shower so much of love and affection. And my coordinators, Dr. Purnima Tiwari, Dr. Manisha Jain, my secretary, Bhopal Ops Gynae Society, Dr. Shabana, always there to, guide us through difficult situations. And with this, we come to the end of the webinar. And the next ISAR Perfection Series webinar 10, and that is scheduled for 19th of January. We already have a very good topic, that is thin endometrium. We have dealt with almost all things, but thin endometrium is something which is very difficult to tackle, especially you've done an excellent septum surgery, you have done Asherman's, you have done, some other good surgery for the uterus, and suddenly you land up with a thin endometrium. We have done an extensive webinar on FGTB. You deal with a case of female genital tuberculosis. You have given a complete course of AKT. You take her for IVF, you have a thin endometrium. Sometimes you have unexplained thin endometria. So this is the topic which will be dealt. Again, we will have a group of clinicians, ART people, as well as hysteroscopy people for this 19 January webinar, and I invite you all for it.
Thank you so much.
Dr. Monica, for joining us, and all the best.
Thank you so much.
I also request, I'm competing for the ISAR membership executive, so I need a support from all ISAR members.
So actually, we are competing from one family. Two of us are competing. We are going for ISAR embryology and ISAR clinician, because you know what, I'm not much of an elections person. I tell my friends and family, the only thing I wanted, when you want to do something good for the society, or maybe, bring about some change, you have to have somebody, some position. Otherwise, Joel would agree. Because his dad is one of the, the path-breaking ART people in India. You hear one lecture of Dr. Manish and your fundamentals are absolutely sorted out. In fact, he has been in ISAR Perfection also.
Ma'am, I have seen how much effort it takes to be a part of the member. So, ma'am, I wish you the very best of luck, because it is a very difficult task to stand in an election and to do good things for the society.
But Joel, but we are the fan of your Papa, that he is still, after I think he was a president, I think 10, 15 years back, and still he is so minute. I was listening his talk in ACE Embryology in Bangalore 2 months back. Perfect. He has presented in half an hour the whole world IVF sector, how the India is promoting. And really, who are still now, Dr. Divya and everybody, in coming 5 years, I'm not going for the politics and all, whether it's BJP or not, but India is going to be the #1 ART centers of the whole world. And for that, we need a good regulation. And now the health ministry has come with a good regulation. So I think we will do best.
And with good regulation, we need good practices. We need good guidelines. We need good mentors. We need to have a good fraternity who support each other, who do not talk about, who do not discuss any colleague in front of any patient. That should be the thumb rule, I think. Whether it is senior, junior, fraternity should be united. And we should have a very good collaboration, like the radiology people, the fetal medicine people, the ART people, the obstetrician, high-risk pregnancy. Everybody, if we are working together, definitely the society and the patient will be benefited at large. Thank you so much for joining. And you have taken
Thank you. Yeah, we are over time. Yeah. Thank you. And Happy New Year, and Happy New Year all.
Happy New Year.
Yeah, because the 31st is the birthday of Dr. Monica, and the 1st January is the birthday of mine. So in advance, we are wishing that.
Happy birthday in advance, ma'am.
Thank
Both of you.
Thank you.
Triple celebrations, a triple celebration.
Thank you so much.
All the best to both of you.
Yeah. Thank you, ma'am. Thank you.
So much. Thank you so much. Bye.
Bye.
Till we meet again. Thank you, Dr. Vishal. Thank you, Intas. Thank you, Mehul. Thank you, Purnima. Thank you, Dr. Divya. Bye-bye.
Thank you so much. Bye.
Thank you, ma'am. Thank you.
Thank you.